One, two, three, go. You can start, sir.
Ruchi?
Yes, Yogendraji, you can start.
Yes. Good evening, doctors. Myself, Yogendra Upadhyay. I am a senior GM for UNS. So, on behalf of Universal NutriScience, the fastest growing nutraceutical company in India and a proud maker of renowned CoQ and Primoza range, I extend my warm welcome all the doctors who are attending this webinar on Fertilogix, a collaborative webinar series in association with MPSR. At UNS, Doctor, we build our foundation on science, clinician, and patient, and we take immense pride to collaborating with Dr. Archana Basir, ma'am, and her team for further shared her vision through Fertilogix and academic platform. Doctor, today's session is on foundation of infertility, evolution, and early intervention brings together some of the most insightful discussion on the reproductive medicines. We are truly honored to welcome our chief guest, Dr. Meenu Agrawal, ma'am, and guest of honor, Dr. Vandana Gupta, whose presence add immense value to this event. Our heartfelt thank you also to our program director, Dr. Archana Basir, conveyor, Dr. Kalyani, co-conveyor, Dr. Rudri Agrawal, and secretary of MPSR, Dr. Brijwala Tiwari, on their effort in curating this meaningful session. We are privileged to hear from our eminent speaker, Dr. Archana Basir ma'am, and Dr. Hitendra Sovani, as well as our moderator, Dr. Sheetal Savankar and Shrutika Thakkar, who will guide us on an engaging panel discussion on red flag in infertility, when not to delay IVF. So, Doctor, we extend our gratitude to all the chairperson, panelists, and participant who have joined us this evening. Together, we will look forward for enriching and insightful learning experience. Thank you, Doctor, and once again, welcome you all for this event.
Thank you so much, Yogendra sir, for that. Good evening, everyone. This is Dr. Shruti from the Medical Affairs team at Universal Nutrascience, and I would like to welcome you all to the fourth series of the Fertilogix. The theme for today's Foundations of Infertility Evaluation and Early Interventions. All of this obviously wouldn't have been possible without our program director, Dr. Archana Basir ma'am, and also the continuous support and guidance of Dr. Brajbala Tiwari ma'am, Dr. Kalyani ma'am, and Dr. Rudri Agarwal ma'am. Dr. Kalyani Srimali ma'am is the clinical director and senior consultant for reproductive medicine at Nova IVF Indore and Ratlam. She has over 17 years of experience and lots of awards and recognitions to her name with various academic contributions too. Dr. Rudri Agarwal ma'am, who's currently associated with Nova IVF as an infertility specialist, has several awards to her name again, has been associated with various organizations, Indian as well as international, and has an interest in reproductive medicine and infertility. With this, I would like to pass on to Dr. Rudri ma'am and Dr. Kalyani ma'am for further proceedings.
Thank you so much, Shruti. A very good evening to all the esteemed guests, respected speakers, and all the faculties and all the participants. It's an honor to welcome you all to the yet another episode of Fertilogix webinar series. Today, we are privileged to have the exceptional panel of speakers, distinguished guests, the moderators, and all the panelists. And we are extremely thankful to all the faculties who took out their time from their busy schedules to share their expertise with us. So, without much ado, can I have the CV of Dr. Rachna Basir, madam? Thank you, Shruti. So, I would like to introduce Dr. Archana Basir, madam, and she is currently holding the position of chairperson MPSR from 2025 to 27. She is director at Akash Hospital Indore and a senior OBGYN IVF consultant. And most importantly, ma'am is the Foxy presidential candidate for the election year 2026. Ma'am is also currently holding the position of Joint Secretary of ISPAT 2025 to 27, and she was an organizing secretary of AICOG 2021 Indore. So, a warm welcome to you, ma'am. Then I would like to have the CV of Dr. Brijbala Tiwari, ma'am. Thank you, Shruti. Dr. Brajbala Tiwari, ma'am, is a senior ART consultant of Indore, and ma'am is currently the managing director of Life Care Hospital Indore, and that is the LCH hospital. And her special work of interest is in infertility, preventive health, gynae endoscopy, high risk pregnancies, menopausal, and preventive gynae. Ma'am has been a chairperson of Foxy Environmental Health Committee 2025 to 27. Ma'am is MPSR Secretary 2025 to 27, Secretary ISOPUB, Indore chapter. She has been the past president of Indore OBGY
Thank you,
Society.
Rudri. Thank you so much.
And
This
to
is
her credit,
enough.
there are multiple awards. We
Thank you.
welcome you, ma'am. We welcome you. Now, I request Dr. Archana, ma'am, to kindly introduce our chief guest and guest of honor for today's session.
Thank you, Rudri, for the kind introduction. At the outset, let me thank all the faculties who have joined in here today and UNS for giving us this platform. A very happy festive season to all of you. To Rudri, belated happy birthday. And
Thank you, ma'am.
yeah, and it is my proud privilege to introduce my dear friend and a very great infertility specialist and a very great teacher who is known world over for her teaching. And she is Dr. Meenu Agarwal, Vice President, International Society of Gynec Endoscopy. She is the first women doctor from India to get this position of ISG as a vice president. She's incoming VP Foxy, course director of international training courses, more than 15 publication in international journal. She has authored 4 books as first author, and she's bachelor in minimum invasive surgery, reproductive surgery from European board certified. We did a course together for Foxy and FMF ultrasound training course online, which was very popular, which was a brainchild of Dr. Meenu Agarwal. And Meenu has really accepted this invitation just on one phone call. We know that infertility is like on a rise. 15 to 20% is the incidence of infertility, and we really need to keep ourselves updated, revise, and know new what is happening in this field. So Meenu is here to give her inputs on this webinar and to tell us a little bit about the topic. So over to you, Meenu, for grace, the kind words, and thank you for gracing the occasion.
Thank you, Dr. Archana, for this very, flowery and very nice introduction. Thank you so much. Dr. Archana, as I know, she's very knowledgeable, very hardworking, very strong, and very intelligent. And she carries both family responsibilities, hospital responsibilities, professional responsibilities with a great balance. So I think from within my heart, if I have to say, she is an ideal candidate for Foxy president because she carries it all in her. So thank you very much. And this is a fantastic webinar that I can see over here. The guest of honor, I think Dr. Vandana Gupta, maybe she has joined. Dr. Kalyani, I think I've known her for a long time. Dr. Rudri Agarwal, Dr. Varsha Lahade, again a good friend of mine from Nasik. Dr. Santosh Gupta. And the first topic that you have kept is modern evaluation of infertility. So basic to advanced. So what is most important when, for the colleagues who are attending it, the junior colleagues, basics are the most important. Don't jump to advanced until you have learned the basics. So my teacher used to say that everything which is advanced may not be necessarily good, so let us stick to the basics, and those basics, then of course we need to also learn the advanced whatever is coming for us to understand. And again, Dr. Hitendra, again very good topic, when to switch to IVF. And I like this topic, red flags in infertility. The red flag word is very nice. So when not to delay IVF, very all my good colleagues and friends very close to my heart, Dr. Sheetal, Dr. Shrutika, Dr. Samhita, Kanchan, then Anaga, Sandhya. Sandhya is again very close to me. Shweta, Dr. Yuvraj Jadeja, I have worked a lot with him for a lot of training courses, and Dr. Shri Abhinaya, and I can also see the concluding remarks to be given by Dr. Brijpala. So very concise, nice program that you have created here. So wish you all the best, lots of compliments. And Yogendra, I've been associated for a long time. मैं जहाँ जाती योगेंद्र तो पहुंच ही जाता है वहां पर. So good to see you over here on this platform. So thank you very much and wish you all the very best. Thank you so much. Thank you.
Thank you, Meenu. It's always encouraging to hear from you and your good wishes. And I hope we keep it to your expectations. And thank you so much. And I think basics are very, very important, as you said, that one has to stick to basics before you. The first step is very important before you go to the top of the ladder. Thank you so much. And now I would like to invite Dr. Vandana Gupta if she has joined here as a guest of honor. Can we see Dr. Vandana Gupta here?
Dr. Vandana ma'am has not yet joined now.
So can we hand it over to Dr. Rudri or Dr. Kalyani to
Yes.
start with the scientific session? There is a slight change. Dr. Hitendra, I think they have communicated, will be taking first before me.
Yes. Thank you so much, ma'am. Thank you so much, Brijbala ma'am, Archana ma'am, and Meenu ma'am for your kind words and motivating words for all of us. Now, without much ado, let me introduce our chairpersons for the scientific sessions. First of all, Dr. Varsha Lahade, madam. Varsha Lahade, madam, is joining us as the chairperson for today's session. Ma'am is a civil surgeon at Nandurbar, Maharashtra, and she is director of Prayag Hospital at Nasik. Ma'am has been playing so many leadership roles and has been holding so many various prestigious posts, including the past zonal coordinator of AMOX, the past president of Nasik OBGY Society. She has been the state coordinator of AMOX 2024-26, and to her credit, there are multiple awards and honors and research publications also. We welcome you, ma'am, as the chairperson. Thank you for joining us. Thank you, ma'am. Then we have Dr. Santosh Gupta, ma'am, as our next chairperson. Ma'am is a senior consultant at Nova IVF Fertility at Bangalore, and she's a joint secretary of Karnataka Society of ART, has been an executive member of BSOG, and to her credit, there are multiple prizes and awards. We welcome you, ma'am, as the chairperson. Thank you for joining us. Thank you, ma'am. Now, I would like to introduce our speaker for today, Dr. Hitendra Somani, sir, who is a senior ART consultant at Bhavnagar, Gujarat. And sir is currently holding the position of Secretary IFS Gujarat chapter. And he has been past joint secretary at IFS and past president at Bhavnagar OBGY Society. And to his credit, multiple awards and publications are there. We welcome you, sir, and would request you to kindly start your lecture. Thank you so much for joining us.
I'll share this. Can you see it?
Yes, sir, the slide is visible. You can change it to full screen mode.
Good evening, respected colleagues. My special thanks to Dr. Archana Baser, madam, the respected chairpersons, guest of honor, chief guest, Dr. Prajbala ma'am, Dr. Kalyani Srimali, and Dr. Rudri, and special thanks to UNS for giving me opportunity to present this talk on when to switch to IVF. The topic is very interesting and very important in day-to-day practice. So why there is increasing infertility in India? Because there are many reasons for delayed pregnancy leading to condition of infertility. This is basically because of the delayed marriages happening these days, high use of contraceptives, increasing number of working women, more and more women, they prefer profession and they plan a pregnancy later, increasing tobacco and alcohol consumption, and this increased prevalence of PCOS, obesity, and sexually transmitted infections. So what are the available modalities of treatment to treat infertility? So at present, we have timed intercourse, drugs, injections, fertility enhancing surgeries, IUI, and IVF. So when to switch to IVF? When there is a tubal factor, malfactor, this can be mild to moderate to severe malfactor, endometriosis, ovulatory dysfunctions like diminished ovarian reserve, POF, PCOS, uterine factor infertility like adhesions, fibroids, and anomalies, fertility preservations, and pre-implantation genetic testing. So when there is a tubal factor as a cause of infertility, we have a choice between fertility enhancing surgery and IVFs. So when to switch to IVF, especially when the age of women is advanced and there's a diminished ovarian reserve, the IVF is a better choice. Number and quality of sperm in ejaculated are low, then we have to switch to IVF. Number of children desired. If the site and extent of tubal disease is extensive, then it is better to switch to IVF. If there are other infertility factors present, then IVF is the better choice. Risk of ectopic pregnancy and other complication, the experience of a surgeon, success rate of IVF program, cost, and what patient prefers. All these factors help us to decide when to switch to IVF. Another important reason is that importance of maternal age and diminished ovarian reserve when to switch to IVF. See, we all know that at birth there are millions of follicles, and at the age of menopause there are only 1,000. So as the age increases, AMH decreases and follicular recruitment also decreases. So there's a if you see the relationship between natural fertility and age, it is an inverse U-shaped curve. And at both the extremes of age, there is a higher chances of chromosomal segregation errors like meiosis. So if you look at this picture, the ovarian and somatical biological clocks in this, as the time passes, there's inflammation, oxidative stress, impaired DNA repair, then there's a mutation, DNA damage, altered methylation. All this will cause to decreased ovarian reserve. And if we look at the causes of diminished ovarian reserve, there can be a genetic and autoimmunity. It can be a socio-demographic, ethnicity, low socio-economic status, medical history, endometriosis, infection, ovarian surgery, pelvic inflammatory disease. There can be an in utero environment like maternal smoking, chemical exposure, childhood environment like LBW, poor weight gain, poor nutrition. In case of adult environment like smoking, drug toxins, chemotherapy, and radiotherapy, all this causing damage. So in diminished ovarian reserve, what happens is that there's a poor egg quality, higher miscarriage rate, lower live birth rates. There are fewer embryos to select, fewer embryos to transfer, lower pregnancy rate, lower cumulative pregnancy rates, eventually resulting to higher cost and more visits. So what choice we have when to switch to IVF in such patients? For this, Poseidon criteria is beautifully devised, in which we put a patient in 4 groups according to age, AFC, and AMH. They are divided into hyperresponders and expected POR. So when such groups, accordingly, we can plan the IVF and we can switch to IVF to give the best results in those patients of diminished ovarian reserve. Other factor is malfactor in infertility, when to switch to IVF. See, generally we call it couple infertile when after 12 months of regular unprotected sexual intercourse if they don't conceive. But malfactor evolution becomes earlier if there's a known risk factors like history of bilateral cryptorchidism, history of chemotherapy, then there's advanced maternal age, or there's a question about the fertility potential of a male partner. As per guideline, men with one or more abnormal semen parameters, presumed male infertility, men in couples with failed ART cycles or recurrent pregnancy losses, this all males should be evaluated in terms of history, physical, endocrine evaluation, semen analysis, and genetics. This is the WHO 6th edition about the semen criteria. So when the sperm concentration is less than 16 million, we should do a endocrine evaluation. If there is a severe oligozoospermia less than 5 million or non-obstructive azoospermia, endocrine evaluation, karyotype typing, assessment of Y chromosome, microdeletion, and in some cases CFTR. So when the count is less than 25 million, so when there is a clinical implication is that if the count is less than 10 million, that is the time this should be considered as a threshold value, and we should be counseling patient about whether IUI or IVF. When the count goes less than 5 million on repeated semen analysis, it is the time to think that IUI success rate may be reduced. And that is the time we have to switch from IUI to IVF ICSI. That is the time we have to switch for the malfactor. So in cases of azoospermia, the causes can be pre-testicular, testicular, or post-testicular. Pre-testicular frequently correctable, testicular generally irreversible except varicocele. Post-testicular are the ones which are frequently correctable. This is management algorithm of azoospermic men. So when to switch to IVF for azoospermic men is that when we think that we are likely to get sperms inside the testis. So there are different techniques of surgical sperm retrieval. The one is TESA is testicular sperm aspiration. PESA is percutaneous epididymal sperm aspiration. MESA is microsurgical epididymal sperm aspiration. And TESA is conventional testicular sperm extraction. By all this technique, we can give a biological child to the azoospermic male. When to switch to IUF in IUI failure cases. A brief about maternal age and success of IUI. In less than 35, the success rate of IUI is 10%. When the age is 38 to 40 years, success rate of IUI is 6.5%. And when the age is more than 45 years, success rate of IUI is practically 0%. So IUI seems to be a poor treatment option for those women, especially above 40 years of age, due to poor oocyte quality. Another thing is the duration of infertility and IUI success rate. If it is less than 6 years, then success rate of pregnancy in IUI is 14.2%. But if the duration of infertility is more than 6 years, success rate of IUI drops to just 6%. So how many when to switch to IUF before how many IUI cycles? In case of unexplained infertility, 3 to 4 cycles of ovarian stimulation with clomiphene citrate or letrozole, along with IUI. If they do not give result, then followed by IVF in those people who have been unsuccessful in achieving a pregnancy. So when to switch to IUF when IUI is not effective, particularly in those patients when both fallopian tubes are blocked and damaged, then when there is ovarian failure, severe malfactor infertility, when there is no sperm, low sperm, poor sperm motility, sperm defects, severe endometriosis, and when the female's age is more than 40 years, that is the time that then we should switch to IVF. In case of endometriosis and infertility, when to switch to IVF? If you look at this algorithm of infertility management, ovarian reserve testing is done. If the POR and more than 37 years, we naturally suggest IVF. If there's a good ovarian reserve and age is less than 37 years, if we suspect on clinical ultrasound that moderate to severe endometriosis, the patient goes for IVF. If there's a minimal to mild endometriosis, we try to correct surgically endometriosis and then give try of 3 to 6 cycles of this ovarian stimulation with IUI or expectant management and ultimately IVF if we do not succeed. So management of ovarian endometrioma and ART. In those patients where the risk of surgical removal, surgical treatment of endometrioma prior to ART. If we remove endometrioma prior to ART, what are the risks? There is a surgical risk of bleeding, pain, infection, injury. The ovarian reserve may decrease. There may be a premature ovarian failure, or there can be incomplete surgery, and chances of recurrence. Surgeon's competency is very important, and there will be a potential delay of ART. So when there is a dilemma, whether to switch to IVF or go for expectant treatment, or whether to remove endometrioma or not. If we leave endometrioma untreated and directly switch to IVF, what could be the thing? There may be acceleration or progression of the disease. There may be a follicular fluid contamination. We may have to use higher doses of the GnRH, gonadotropins, cost and side effects. There may be undiagnosed occult malignancy inside. The cycle may get cancelled, or we may face challenges in oocyte retrieval. There may be a chemical peritonitis because of contamination, or there can be a serious complication like infection to endometrioma leading to abscess, or there can be a pregnancy-related complication when patient conceives. So if the endometriosis is diagnosed, the choice is between surgery and switch to ART. When the woman is in late 30s, there is no point in delaying management to expectant management and putting ART at later date when the ovarian reserve already decreases. The present evidence does not support endometriotic cystectomy before IVF because surgery-related decrease in ovarian reserve surpasses the risk of conservative management. So this is the ASHRAE recommendation. So role of IVF in unexplained infertility, when to switch to IVF. IVF is not probably recommended over IUI with ovarian stimulation in couples with unexplained infertility. The decision to switch to IVF is individualized by patient characteristics such as age, duration of infertility, previous treatment, and previous pregnancies. The ICSI is not recommended over conventional IVF in those patients of unexplained infertility when it is required. So in unexplained infertility, we give 3 to 4 cycles of ovarian stimulation with CC or letrozole, followed by IUI. If not successful, we can switch to IVF. This is the algorithm of management of unexplained infertility. When the couple comes with unexplained infertility, the prognosis depends upon various factors like age, duration, previous pregnancy, motile sperm count. And if we calculate that she is likely to become pregnant in next 12 months, in more than 30% of the cases, then we should offer 6 months of expectant management. If we feel that she's less likely to become pregnant, less than 30% in next 12 months, then comes the role of IUI with ovarian stimulation, minimum 3 to 6 cycle. If you are not successful, then we should switch to the IVF. So polycystic ovarian syndrome, when to switch to IVF? In India, nearly 50 to 60% of the infertile women, they suffer from polycystic ovarian disease. So when it comes to PCOS, in absence of obsolete indication for IVF, ICSI, IVF should be offered in women with PCOS and anovulatory infertility if the first line treatment with letrozole comifen citrate or second line treatment with gonadotropin fails. The advantage when we do IVF in PCOS patient is that it is effective, and when we do single embryo transfer, we can minimize avoid the multiple pregnancy. So role of IVF in management of recurrent pregnancy loss. IVF for PGTA testing in RPL. So PGTA is basically evaluation of embryo for aneuploidy with the goal of identifying a chromosomally normal embryo for the transfer. At the age of 30, the rate of aneuploidy in biopsy is just 23%. At the age of 35, it is 34%. And at the age of 45, it is 84%. So at the age of increases, the chances of abnormal embryo increases. So aneuploidy results from meiotic errors. There may be a premature separation of sister chromatids in first meiosis and whole chromosome disjunction in second meiosis. So aneuploidy is most frequently seen in chromosome 13, 15, 16, 18, 19, 21, and 22. This is important because these aneuploidy gives rise to results in clinically detectable abnormal pregnancy. We may detect a pregnancy, but those pregnancies are abnormal. And not simply they give rise to implantation failure. There can be a Y chromosome aneuploidy also. So why IVF? When to switch to IVF in recurrent pregnancy loss? To do PGTA, because PGTA causes a decreased time to pregnancy. It is especially important in those patients with advanced maternal age, with recurrent pregnancy loss, with recurrent implantation failure. So this PGTA testing may be unsuccessful when there are accidental damage to embryos, loss of embryos, but PGTA lacks a standardization of process because of the multiple available platforms, significant variation in laboratory techniques, and training among the different centers. So a paper about pre-implantation genetic testing for aneuploidy in unexplained recurrent pregnancy loss, systemic review and meta-analysis. So in these two groups where embryo transfer was done in two groups of patients, one was PGTA tested and other was not PGTA tested in those patients suffering from unexplained RPL. So when it came to this pregnancy rate per embryo transfer, live birth rate per embryo transfer, it was more in PGTA tested group and it was less. Clinical pregnancy loss was less in PGTA non-tested group. Again, the live birth rate per patient was higher in PGTA tested group and clinical pregnancy rate loss was less in non-PGTA tested group. So a role of genetics and infertility. Basically, we like to find out the genetic cause of infertility is because to establish the cause and diagnosis, to personalize the therapy, and to prevent the recurrence in next generation. These chromosomal abnormalities can be aneuploidy, deletion, microdeletion, duplication. In deletion, it removes the chromosomal segment. Duplication, it repeats a segment. Inversion, there is a reverse of segment. In translocation, it moves to other chromosome. There can be a reciprocal translocation also. So in IVF, aneuploidy screening is gaining importance. Why? In especially those patients, when we switch to IVF for advanced maternal age, recurrent pregnancy loss, recurrent implantation failure, and role of aneuploidy screening in those patients where the suboptimal sperms are used for ICSI. So there is something PGTM is to establish a pregnancy that is unaffected by specific genetic characteristics such as non-heritable pathogenic variants that are carried by one or both biological parents, or when to select the embryo for transfer that have specific characteristic like particular sex, which is not allowed in India, or HLA compatibility. So PGT-SR, the goal of PGT-SR is to establish a pregnancy that is unaffected by structural chromosomal abnormality in a couple with balanced translocation, deletion, or duplication. What is advantage is that it may actually distinguish the normal non-carrier embryos from balanced carriers. So role of IVF in fertility preservation, indication of oocyte preservation. There can be a medical indication, non-medical indication, medical oncofertility, genetic disease, non-malignant condition, failure to obtain sperm. This non-medical can be a plant oocyte cryopreservation, egg banking, embryo cryopreservation, and others. So this is a plot especially in those patients who are undergoing breast hematological malignancy, or in those patients who are going for chemotherapy, radiotherapy. We can go for IVM, we can do a oocyte cryopreservation, we can do a embryo freezing, we can do a ovarian cortex cryopreservation, and further transplantation and stimulation when the malignancy is resolved. When there are non-oncological conditions that require cryopreservation, like endometriosis, planned for a severe endometriosis when it is planned for a surgery, autoimmune disease plans for gonadotoxic therapy, diminished ovarian reserve, those undergoing for a gender change. So oocyte cryopreservation, particularly in case of endometriosis, endofertility is becoming increasingly important for those patients with severe endometriosis. So we use oocyte cryopreservation as a salvage procedure when there's an inability to obtain the sperm on the day of oocyte retrieval. This may be due to unavailability of a husband or is unable to give. This may be due to failure to obtain, extract the sperm in tese or microtese, or when we are doing a egg pooling to use subsequently in those patients who are having a non-obstructive azoospermia. So in such cases, we can use cryopreservation of the oocytes. This particularly elective oocyte cryopreservation is gaining very much importance these days because more and more women are going for carrier. They are opting their carrier, they are going for carrier, and they plan a pregnancy at very later date. So they like to preserve their fertility. The only way to combat age, the aging process, is by freezing the oocytes. And for this, we have oocyte cryopreservation. They preserve the oocytes are ovaries are stimulated, oocytes are cryopreserved, and they are kept for a time till the time it is convenient for them to go for a pregnancy. Another indications are planned female to male transition, traumatic injury, divorce, or remarriage. Then a word about semen cryopreservation. This is again increasing importance, and it is very easy to do semen cryopreservation in those patients going for chemoradiotherapy, those with autoimmune disease, those patients with severe oligozoospermia coming to our OPD with very low sperm count. We can just freeze, and if they are not willing to switch over IVF, we can give them some trial of IUI, but we can keep the 2 or 3 sample frozen so that we can use it in future should they require IVF. Then cryopreservation of the donor semen. This is a chart about male fertility preservation. A word about erectile dysfunction. There are a variety of causes, right from obesity, diabetes, chronic disease, stress, anxiety, depression, to unfavorable weather for erectile dysfunction when everything fails. See, first we have to identify erectile dysfunction, like what are the risk factors, counsel the patient, psychosexual dysfunction, medication, devices, and surgery. When everything fails, switch to IVF is the last option. That is where we can help with the patient with IVF. Another indication is IVF to shorten time to pregnancy. This is very important because in olden days, implantation rate was just 5. And now the implantation rate is increased to 50% after embryo transfer. The safety during IVF has increased. Previously, there was a low implantation rate. Now it is increased by getting more embryos by aggressive ovarian stimulation. Previously, there was a OHSS, multiple pregnancy. Now the OHSS free clinic, because these days what we are doing is that we are doing controlled ovarian hyperstimulation, antagonist cycle. We are giving agonist trigger. We are doing freeze all. We are doing PGTA and doing single embryo transfer in a modified natural cycle. So this is giving the best result. Now, how the IVF has shifted in laboratories. In late 80s, the IVF specific instruments like egg collection kits, ET catheters, pumps that allowed the aspiration of follicular fluid were discovered. In late 80s, again, the laminar flow came, workstation equipped with heated surfaces were engineered. Then there came the ICSI machine. And now embryos are cultured for a longer time up to blastocyst, expanded blastocyst stage. We have best incubators, and development frame of embryos can be watched by time-lapse microscopy, which is incorporated into the incubation system. We have frozen embryos. We have facility to transfer. See, in olden time, what was there is that IVF had very limited success. There were too many side effects. But now, with advent of all this, we have IVF with a very high success rate and very low side effects because of frozen embryo transfer and agonist trigger. So time to pregnancy and IVF is emerging as a major tool to fight infertility with highest success rate, but we must be very judicious to use indication time to shorten the pregnancy. With this, thank you so much for giving me opportunity. It was very wonderful to be with MPSR chapter. Once again, thank you so much, UNS, and thank you, Ashna Basir Madam, for giving me opportunity.
Thank you, Hitendra. And thank you for switching over, like pitching in for me when, yeah.
Thank you, sir. Thank
Nice.
you so much for the beautiful, wonderful, and the crisp lecture. I think you have covered each and every minute details. So thank you so much for accepting the invitation and taking the lecture for us.
My
Thank you,
pleasure
sir.
and honor. Thank you
Thank
so
you, sir. Then going forward with our scientific session, I would request Dr. Archana Basir ma'am to start with her lecture, and then we will conclude the sessions with the chairperson. So I request Archana ma'am.
Yes.
Thank you.
Hi, good evening, everyone. At the outset, let me thank all of you for joining in. And the topic allotted to me by my convener is really very big topic. But I have done only I'm just going to take few things because Hitendra has covered quite a few things. My topic is evaluation of infertile couple, basically modern, basics, and beyond. Right. So I would like to begin by saying our future success is directly proportional to our ability to understand, adopt, and integrate new technology into our work. Now, if we look into the infertility evaluation, the basic infertility evaluation or standard map of infertility evaluation, the first and foremost is like history from the couple. Gynecological examinations, smear, swab, investigations for microbiota, which is a new thing now, baseline investigation of both the partners, pelvic ultrasound, endoscopy, male partner investigation, and genetic evaluation of the couple. But I have highlighted these three things: history, gynecological examination, and pelvic ultrasound, just to keep it within the time frame. Now it is when you go for all the investigation, this is a whole list of investigations. You can choose from it. But it's a practical point I want to tell here to all who are logged in and all delegates here, that when a couple is moving for infertility treatment from one consultant to other consultant, or one clinic or one city to another city, they all have big pile of file and big papers, and many a times investigations might have been recently done. So infertility is not only a disease, it is basically a lot of social burden, and plus it is really emotionally draining for the couple. So we as a consultant, we as an infertility specialist have an onus lies on us that we look into the files, see if the investigations have been recently done. So need not repeat those investigations, do the investigations which are going to lead us to the diagnosis. So this is a list of investigation for the male factor like serum FSH, total USG, testicular volume, Doppler, karyotype, and testosterone. Now the big question which we should ask ourselves is what investigation to be offered. As I said, result of an investigation which will lead us to a diagnosis and help in further treatment plan. we understand this by the case-based investigations which I have brought here. I think an algorithm or roadmap was given by Dr. Hitendra that what you will do a clinical examination, take a history. If everything is good for initial 3 months, just give them the good ovulation days. These are the ovulation days, maybe IUI, and then switch over to IVF by the end of a year of treatment. Now, I mean, everything is basic I'm talking here. So what is modern? I think modern is to individualize investigation as per the need, not that all investigation are to be offered to everyone. So first and foremost important thing is the history. History taking is very, very important because many a times when a patient is coming to infertility clinic, we miss out on very basic points in the history which may be relevant to her current problem of not being able to conceive. And second very important thing is a clinical examination. At many times we find that women coming to us with infertility, their pap smears sometimes are missed out, and their clinical examination, especially the speculum examination, is missed out, and we find that they have got like big erosions or big ectropions, and when we take the smear, the abnormal reports come. So it is important, if a patient, even if she's coming to you for 6 months for follicle study, for treatment, in between, it is important that we do their speculum examination and at least have a look at their cervix, because these days microbiota is also being talked about a lot, that there is a change in the dysbiosis which may be responsible for infertility. I'm mainly going to focus on ultrasound because that is something which I feel is accessible to all the clinicians. It is acceptable by patients, and it is relatively economical. When you take it in terms of the biochemical investigation, it is economical and it is readily patient would agree for it, and it skill can be acquired easily by perseverance. And one more important thing about ultrasound is biochemical parameters may not change when you are talking about, say, 3 months duration, but ultrasound, when you see picture in follicular phase, luteal phase, from one cycle to second cycle, appearance will be different. So it is important that we all learn to do ultrasound, or at least even if we are not doing ultrasound, we learn to interpret ultrasound well. So now the important thing is evaluation of female pelvis by ultrasound, especially all the time when a woman comes to gynec clinic or during infertility management, you should know how to do sagittal section, transverse section, and what is important is normal uterus dimension, shape and direction are to be written clearly, whether the shape of the uterus is arcuate, bicornuate, single, diadelphous, adenomyosis, fibroid, malformation, adenomyotic cyst, even the Nabatean follicle in the cervix. If you see large ones, sometimes they are multiple and they can be confused with the follicles in the ovary. So it is important that you do the anatomical survey well. Hydrosalpinx, para-ovarian cysts, all can be picked up by ultrasonography. So we are living in a modern times when we have high resolution machines. So if there is any anatomical cause for the subfertility because of the female reproductive tract, we should be able to diagnose it there and there only in our consulting with the ultrasound. Now, the another thing is, like, should we be doing AMH in all the women who are coming to our infertility consulting? I think we have to be judiciously using the investigation and AMH to be offered only after doing your ultrasound, and when you find that ovarian volume is less, or the women's age is more, or if her AMH, she has come with a report which was very low, and then you just want to compare it is further down, or any treatment is being done for like PRP or stem cell therapy, and you want to review it. So let's look at, rather than going through investigation, what to be done, let's go through case-based. I have recently had a case who is 26 years old, came from UP. She was getting ovulation induction for 1 year. She has no conception. And all baseline investigations were done. Husband semen analysis were normal. I think they were focusing on the endometrium, and uterus was never evaluated, only endometrial thickness was seen. When I scanned her, I found that she has a unicornuate uterus. So look at her ovaries. Ovaries looks okay, and this is a unicornuate uterus. We did her laparoscopy. What you see here is the uterus, and here is the bulge, which is the unicornuate uterus. So this is a unicornuate uterus with a patent left tube. So now to counsel this patient that you have uterus, you have only one tube functioning. So basically her chance of fertility is 50% less than her counterpart of the similar age because she has only one tube patent. So it is important that the shape of the uterus is ascertained by ultrasound, and if there is any Mullerian anomaly, it is to be picked up, which can very well be picked up by ultrasound. Always, all the machines nowadays, most of the machines have the 3D volume probe. You just put the 3D volume probe and you will be able to find out the shape of the uterus. Now, this is second case scenario, a young couple. This is just from the history. A young couple, 25 years, this was just 2 days back. She was 89 kg. Her male partner is 28 years. They're trying to achieve pregnancy from almost 1.5 years. Day third of the period, she came to me. Her cycle length is 25 to 26 days. Scanty flow in periods. Again, they've been tracking ovulation, they've been taking medication. When I dig down the history, it came up that she never had spontaneous period. It is always a withdrawal bleed. So means it should red flag you, oh, this woman is not having her regular periods. Maybe she had some illness which might have destroyed her lining, or she might have had some kind of a DNC or something which, or maybe she has a hypothalamic hypopituitary so that she's not menstruating on her own. What she's told me that she probably, that I survived a very serious disease in childhood. I had some problem in my lungs. Maybe my parents don't know because they are from village setup. Maybe she had some primary complex. Maybe she had a COX, and that has really, caused her the damage to her endometrium. So basically, in such cases, when you get this history, you need to extend your panel of investigation, because it is not only going to suffice your routine biochemistry, because history itself is telling that there is a problem. And then her ovarian volume, I'll show in the picture, was very less, and her endometrial cavity was also very thin and irregular. We offered her FSH and AMH, and to us, we expected that her AMH is going to be low. It is 0.007. So this is her endometrial cavity. Look at the endometrial cavity, it is thin. And when you look at the ovary, it's a small ovary with just one follicle, a young woman when she's not getting any periods. So these are the practical things which you have to keep in mind. And this is a case where 26-year-old again, she had one cesarean section and 2 mid-trimester abortions. I don't know why. And she has a history of DNC done for that. So on scan, we found that she has intrauterine adhesions. And look at the hysteroscopy, how bad these adhesions are. They're quite thick band of adhesions. And adhesiolysis was done using energy source. And this is a normal positioning of uterine ostia in the cavity. Now, there are so many things which can be picked up on ultrasound, like hemorrhagic cyst of ovary, PCO you can see on the ovaries, and then hydrosalpinx, 33-year-old primary, subfertility, rest all investigation in normal limits, ultrasound, unilateral hydrosalpinx. Lot of discussion, I think, will be needed. Maybe that I hope that panel take and deal with these kind of questions, because the primary subfertility and hydrosalpinx, really, it is very tough to counsel regarding surgical excision. So this is a right adnexa which is showing the hydrosalpinx. So maybe she might have had some infection, some PID or something. Now, what is modern and new thing which is coming up is a microbiome and microbiota. A healthy vaginal microbiota is dominated by lactobacillus, maintaining a protective acidic environment, while dysbiosis increases risk of infection, preterm birth, infertility, and cervix relies on lactobacillus for mucosal defense with pathogenic overgrowth impairing sperm survival. So this is something new which I think we might have to start doing it on a regular basis, though it is expensive at the moment. If you have a couple who have recurrent implantation failure, or women who have not been able to conceive and they have an infection at the cervix, I think it is important that we check their endometrial fluid and send it for sequencing and find out the lactobacillus and all. So I think just to cut short and just to limit in time, I think the secret of change is to focus all our energy not on fighting the old, but on building the new. And the new thing is that we should find out what is new in IVF, what keep ourselves updated and limit, like just do just enough. Don't overdo, don't underdo, and take care of the patient very empathetically, because infertile couples are really they are in a lot of stress, and we really need to have counselor and we have to look into their psyche also. So the future of infertility management lies in harmonizing technological precision with holistic care to optimize both clinical outcomes and quality of life. Thank you very much for the patients listening, and I'm going for Foxy President 2026. So look forward for support from all of you. Thank you.
Thank you, ma'am.
Thank you, Dr. Archana, for such a wonderful presentation. And I couldn't agree more that scan are like eyes and ears of fertility specialist. So very good scan and a detailed scan with eyes like eagle, I think can solve most of our problems. First, good scan and done by a fertility specialist is very important. So I couldn't agree more. And yes.
Yeah.
Thank you. Thank you for your kind words. Yeah, Varsha.
Yeah, it was wonderful, Dr. Archana Basit, and you have done very good job. What is like basics to be on, and as your experience counts, you have explained in the same manner. I wanted to just comment on Dr. Hitendra's Somani's talk. He has covered everything. Wonderful talk, and really it shows it was an evidence-based and insightful talk by Dr. Hitendra, and both talks were very wonderful, and we were happy to hear both of you. Thank you so much, and thank you, Archana ma'am, for giving me opportunity as the chairperson here.
Thank you, Dr. Thank you so much. Just one phone call and you, I mean, not phone call, just WhatsApp, you responded so well. So thank you so much, dear friend Varsha and Dr.
Thank you.
Thank you, ma'am. Ma'am, I would just like to request you that Vandana ma'am has also joined us now. So kindly, I just request you to welcome Vandana ma'am.
Yes.
Can we have the CV? Yeah.
Hi, Dr. Vandana.
Hello. Thank you, Dr. Archana, for this opportunity to be there.
And I remember our meeting in Delhi. And since then, I was thinking that I would like to invite you on one of our webinars. I think she's a very friendly, very jolly person. And she's senior consultant, obstetrics and gynec, Max Hospital, Patapganj and Apex City Hospital. She has membership of so many organizations, IMA, Delhi DGF. I think, I mean, like so many, I can read it and it for all day. But main thing is she's coordinator of Delhi Gynec Forum and chairman of GDM and stillbirth prevention of DGF, that is Delhi Gynecologist Forum. And her special interest is infertility, adolescent health endocrinology, emergency obstetrics, gynec endoscopy, menopause clinic, and colposcopy. So, Dr. Vandana, we welcome you on this our webinar, and please give us your blessings and your inputs.
Thanks, Dr. Ashna Basir, for giving me this opportunity to be there. And it has been really wonderful interacting with you. And the topics you have chosen for the day are very relevant for today's scenario, because we see rising infertility because the couples are delaying their pregnancy. Either they are getting delayed in marriage also, and delaying their pregnancy because of their career prospects. And then there comes the role of the history, detailed history. And this history, I think, was the basic. But the modern part, many times the clinician may get overwhelmed by everything being introduced in this world. But as you said, we do not We may not need all the investigations. We really have to tailor make according to our patient's requirement based on her history. And ultrasound, yes, readily is the one of the most accessible, non-invasive, and patient-friendly investigation. And really, it gives us a lot of insight. And all the investigations have to be tailor-made according to the patient's need, whatever the male partner requires, whatever the female partner requires. And I agree with Dr. Hitendra that we have to see to it that we shorten the time to pregnancy, which is the most important part. And the patients are restless because they are aged and they want pregnancy as soon as possible in this fast moving world. Thanks for picking up nice topics for deliberations, and they are very relevant for today's clinical aspect. Thank you. Thanks again for inviting me.
Thank you, Dr.
And sorry
Archana.
for late joining.
It's okay. It's okay. We all understand each other because we are all gynecologists.
Right, right,
Unpredictability is the most predictable thing in our life.
right, right. Thanks a lot.
Over
Thanks a
to
lot
you.
again.
Please stay with us.
Yeah, I
Interesting
am.
panel. So over to you, Dr. Rudra. Invite the panelists and to take further. I think I'm looking forward to an interesting panel.
Yes, ma'am. Thank you, ma'am. Thank you, Vandana ma'am, for joining us. And I would like to express a sincere thanks to Hitendra sir and Archana ma'am for the very wonderful. Now, going forward, we have a very brainstorming panel discussion. And for that, we are having very experienced moderator and panelist amongst us today. And the topic for today's panel discussion is red flag in infertility. That is when not to delay IVF. So, for the this panel discussion, I would like to introduce our first moderator, Dr. Sheetal Savankar, ma'am. Shruti, may I have the CV, please? Hello, am I audible?
Yes, ma'am. Are you able to view the slide?
Yes. Yes, okay. So, I heartiest welcome Dr. Sheetal Savarkar, ma'am, for joining us as the moderator for the panel discussion today. And ma'am is a senior executive member of MSR 2023-25, and ma'am is director at Avisa IVF and Fertility Center in Mumbai. Ma'am has been a recipient of various prestigious awards, and to her credit, there are multiple publications and awards, and she's holding special interest in the mild stimulation protocol in the poor responders and RIF. We welcome you, ma'am. Then we have Dr. Shrutika Thakkar, ma'am, as our next moderator. Ma'am is medical director at Medansh Multi-Speciality Hospital in Mumbai, and ma'am is working as a consultant OBGY at Fortis Jupiter and Hiramongi Hospitals. Ma'am is also a managing council member of Maharashtra State Chapter of SR and has been a youth council member of MOGS since 2015. And to her credit, multiple awards and publications are there. We welcome you, ma'am, as the moderator for today's panel discussion. Then we have a very experienced team of panelists amongst us. First of all, I would like to introduce Dr. Samidha Madam amongst us. Ma'am is Director and Chief IVF Consultant at Pune IVF Fertility Center and Research Institute in Saudagar and Manchar. Ma'am is IVF Consultant at Shalinta Meghe Medical College, Nagpur, and an Honorary Consultant and Teacher at BJ Medical College, Sassoon Hospital. And she was a former IVF consultant at Jupiter Hospital, Nova IVF, Leela Hospital, Pune. We welcome you, ma'am. Next, we have Dr. Kanchan ma'am as our next panelist. May I have the CV, please? Yeah, thank you. Dr. Kanchan ma'am is the founder and director of Grace IVF at Dhanshri Hospital, Mushi, and she has done her fellowship in laparoscopy at Nadkarni Hospital, Gujarat, and she has published multiple papers and she has been awarded with multiple prestigious awards. We welcome you, ma'am. Next, we have Dr. Anagha Pai, madam, as our panelist. Can we have the CV, please? Thank you. Ma'am is working in the present in Pune, And ma'am has done her fellowship in IVF and ART at Miss Midi Hospital, Seoul, South Korea. And she is an IVF consultant at Cloud9 Hospital and Dinanath Mangeshkar Hospital. And she joined treasurer of POGS in 2025 to 26. We welcome you, ma'am. Next, we have Dr. Sandhya Mishra, madam, as our panelist. Ma'am is a fertility consultant from Pune, and she is affiliated to Cloud9 Hospital, Pune as well. She is Joint Secretary of POGS 2025-26 and a Managing Committee member of POGS since 3 years. And ma'am has been a recipient of multiple prestigious awards. Thank you for joining, ma'am. Next, we have Dr. Shweta, madam, as our next panelist. Ma'am has done her fellowship in ART from Kraft Hospital, Kerala, and she has been a gold medalist and has been a senior ART consultant. She has been joint secretary in EDGF in 2025 to 27 and executive member of Delhi SR, and she has published various publications and articles in various index journals. We welcome you, ma'am. Then we have Dr. Yuvraj Jadeja as our next panelist. Sir is practicing in Gujarat in Anand, and he is a medical director at Nimaya Women's Center, Vadodara, associate professor and head of the department at Shishu IVF Dheeraj Medical College, and he has been a recipient of Budding IVF Specialist Time Celt Award 2023, and he has been an invited speaker at various prestigious conferences, and to his credit, multiple publications are there. We welcome you, sir. Then we have Dr. Shri Abhinaya as our next panelist. Ma'am is consultant at Nova IVF Salem and an executive committee member of Salem chapter of TAP ISAR, and she has participated as faculty and presented papers in various conferences. We welcome you, ma'am, as our panelist. And I request to take the panel forward Dr. Sheetal, ma'am, and Shrutika, ma'am.
Thank you
Hi,
so much.
Shri. Yeah, go ahead, Shrutika.
Yeah, just allow me to share. I think you'll have.
Thank you, Archana ma'am, for this opportunity. Thanks, Kalyani. Thanks, Rudri, and the whole team of MP. Thank you so much. So I hope we try to do as much justice as possible. Thank you so much, ma'am.
Yeah. Also, thanks to the entire team of UNS for this wonderful program on a very, very basic topic that will benefit a lot of people on red flags in infertility when not to delay IVF. So, welcome to all our panelists. So, let me start with a brief introduction. A wise man once said that we should choose our battles very, very wisely. And both Sheetal and I wouldn't agree more about this because when we do go to battle, we like to win and win. And we usually win in style. But how we do it is what we all have to think about. Because winning a battle always means, what do you think? Is it aggression and strength, strategy and planning, ammunition, weapons, or raw emotions and motivation? But if you actually think of it, it is usually strategy and planning that is the whole crux of winning any kind of battle. And that is true for our battle against infertility also. To have proper strategy, to have proper planning is winning the battle against infertility. And it is of paramount importance that we have the strategy in place. Okay, so because action without direction always leads to failure. And you should know ki when a particular patient should be for IUI, when for IVF. And it is our job as fertility specialists to help them decipher this labyrinth of options. So I request Sheetal to take the first case.
Yes. So what are the objectives of this panel is to evaluate a very subjective matter, because I think as IVF consultants, we have so many times, we see so many gynecologists doing 10 IUI cycles, 12 IUI cycles, just keep doing IUI cycles. So for that reason, I think this topic was very, very important. And it's very important to know when to convert an IUI to an IVF cycle, or when do you need to do an rescue IVF. Identify the strictly no red flags zones where IVF, and that should be the only option. Please try to keep your points very specific, crisp, and then there should be good take-home messages. Next slide, please, Shrutika.
Yeah, I request all the panelists to turn on their camera because webinar, it is very confusing for us to know whether the panelist is attentive, present or not. So it'll be helpful.
Yes, so we start with the first case. She's a patient who is around 36 years old. She's a nulli gravida. The semen analysis is normal. The hormonal profile is normal, and she's had 2 failed IUI cycles with gonadotropins. So, what will be your next step? Anybody can take it. Yuvraj, are you there? You can start with your answer.
Hi, thank
Hi,
you so much
Yuvraj.
for the question.
Hi.
I
Yes.
think 36 years is a little bit of gray zone, but I think two things that will matter to me is the duration of infertility. So, for example, if it's a 36-year-old female but married since 1 year, I
Hmm.
might still give them a chance for maybe one IUI or a few more months. And of course, the egg reserve, if that's something that they allow. But if a
Hmm.
patient has been married for 5, 6 years, 7, 8 years, trying since naturally since multiple years, and then done to IVF, I would definitely put a discussion of skipping the third IUI and straightforward thinking of an IVF. I, yeah, I think that's in short what I would go ahead, provided the male factor is normal, of course.
Yes, that's normal. But
Yeah.
Yuvraj, do you think that after 2 failed IUI cycles with gonadotropins, would you still want to give a third attempt? And as in, or
So
you,
yeah, I mean, you're right. As we all know that as the IUI cycles increases, the number of the success, if it's not in the first, the second is less, and in the third, it's even less. Uh, I would look. We are all IVF specialists. I would love to go ahead and do an IVF and get her pregnant. But
yes,
textbook wise, probably if everything else permits, I might still agree to doing a third IUI if the couple wants it. But
yes.
my preference would still be to go ahead and do an IVF. Again, as I said, provided if the duration of infertility is not that long and her reserve is good at 36.
So, Samida, what's your take? And do you think we are different from the Caucasians and do we age early? Samida, are you there? Any other panelist can take the question.
Dr. Sandhya or Dr.
Yeah,
Abhinay?
hi, Dr. Sheetal. I think I'll take it up.
Yeah.
Yes,
So in this case, I would like to first know her ovarian reserve. It
yes,
hasn't been mentioned. So first of all, I'd like to order an AMH test as well as look at her AFC count, and then take a call. If and besides, in the second very question, you have that the Indian scenario is actually different. We age faster than the counterparts all over the world. Our
yes.
ovaries age faster. So if she's 36, actually, she's would be around 40 years. That is what is the age, the ovarian reserve, which I would be expecting in her. So depending on her AMH and AFC values, I would like to counsel her whether she should go ahead for another IUI cycle or straight away switch to IVF.
Very
Yeah.
lightly mentioned by Dr. Shweta. I think this is a slide. It's an Indian study by Dr. Firoza Parekh, where the AMH for Indian women is very different from the Caucasians.
Yes.
Indian
And
scenario.
in fact, there's a steep fall also. Like if you see the graph, it clearly shows that Caucasians have a decline a little later compared to the Indians. So that's why you have to be very, very cautious as to how soon or what is the next step that you are supposed to take. So this was a study which was done, and if you see anything above the age of 35 or 36 and 39, if you see the pregnancy rates start going down, and especially after the woman crosses around 40, then I think the best option is to go for IVF or maybe ICSI. That's a better option. Next slide, Shrutika. Anybody else has a different take? What will you do in that case? Just like a thought.
So, yeah, I would like to take up
Yeah,
that.
Dr.
So,
Sandhya,
as
yeah.
we discussed, the Indians age, to be very precise, almost 6.7 to 7 years faster than the Western counterpart. So that is almost the lag. I would think that I would do as we discussed that depending on the age of marriage and also the ovarian reserve. I would
Yes.
preferably after 2 cycles, if they still want a third IUI cycle, I would go do a hysteroscopy, do an endometrial evaluation, and then probably do the third IUI. So that if that would be a little bit better probably.
Even
So that
after the endometrium is
endometrium.
normal, you'll still go ahead with the
Yeah, yes,
hysterectomy.
yes, because
Okay.
sometimes that definitely helps. That is what I've seen with in my practice. And also, if they're very very keen on a third IUI, I think after hysteroscopy it would be because small micro polyps or which might get missed on an ultrasound I think removing those will definitely improve the fertility. In the third cycle, probably it will be better. So that
But
is
do
my
you do any kind of endometrial microbiome profiling if you are doing hysteroscopy?
Yes, I do. I sometimes do send the DICE panel and the endometritis panel, and if required, we can put them on a prolonged doxy course or whatever the culture.
Yeah, endometritis is also very common in India. So yes.
Yes, yes.
This
So
is a
probably you could
very
correct that
good
and then
approach.
probably do one more of IUI if they really insist on that. And any which ways we will be requiring, if you are even going for an IVF, we will be requiring hysteroscopy. So again, that will be additive and it will help in the further action as well.
Yeah, so I think to brief this case, it is very important to see which kind of protocol was given, what is the ovarian reserve, what is the age, because in the Indian scenario, we age a little faster. So I think you have all covered all the points. So maybe Shrutika, you can take the next case.
Yeah. Coming to the case number 2, a lady of 32 years of age with secondary infertility with a 2 centimeter persistent cyst on ultrasound scan, and the cyst is still persistent after 2 cycles of OC pills. Diagnostic hysterolaparoscopy has revealed that there are endometriotic spots on the uterosacrals, and it confirms that the cyst is an endometrioma. The tubes are patent, semen analysis is absolutely normal. It's a case of secondary infertility. So what do you want to do? IUI or IVF in this case?
So can I take up this case?
Yeah, Dr. Abhinay.
Yeah, this patient age is first 32 years and she is a case of endometriosis. So I would look into her ovarian reserve. So I would first check her ovarian reserve. So if the ovarian reserve is less, I would definitely not wait. Would proceed ahead with IVF. If she has a good ovarian reserve, since the tubes are normal, we would counsel her properly and maybe I would take for 1 or 2 cycles of IUI.
Okay, and so why is your cutoff 2 cycles of IUI?
Because of her age. Again, her age is 32 years.
32.
So yeah. So I just and she's a case of endometriosis.
Okay, vis-a-vis endometriosis, I want the views of say Dr. Shweta, if you can answer this. Depending upon grade 1 endometriosis, grade 2 and severe endometriosis, would your decision to do IUI cycles differ?
Actually, the catch in this case is that she's pretty young. She's 32 years only. But simultaneously, also she's grade 4 severe endometriosis. So any kind of an endometrioma actually makes it a grade 4 endometriosis. So if we were to just look into the fact that she has severe endometriosis, then definitely we have to take her up for IVF. But she's 32 years old and she has secondary infertility. Presumably, if I presume that she has a previous life issue, then those are the factors which are going in her favor. So if her AMH is nice and if she's convinced, okay, fine, we can give her a trial of 1 cycle of IUI.
Yeah, so that is what international data also suggests, that performing IUI in moderate to severe endometriosis has limited efficacy. So we are not sure whether this will work. What about GnRH agonist or the recent favorite oral antagonist? Would you be giving any of these things after the hysterolaparoscopy to opt? And if your plan is IUI, would you give it before an IUI, say, for example?
So now, previously those long cycles, long GnRH agonist cycles were taken up, but now it has shown that both antag as well as agonist cycle, they work equally. And if we have done a laparohysteroscopy for her, we have done a cystectomy for her, then there is no need to suppress her with further GnRH agonist. She should go in for, her pregnancy immediately.
But Dr.
as soon
Shweta,
as
would you do a cystectomy for a 2 centimeter endometrioma?
Since the laparoscope is already inside,
Agreed.
Had it not been inside and it would have been just picked up on an ultrasound, then yes, obviously the cystectomy is not warranted in our case. Cystectomy in endometriomas are only warranted if she's having a lot of pain or if it is going to interfere with any follicle aspiration, not per se.
So that's a very valid point for our audience watching us. Just for a 2 centimeter endometrioma, there is limited scope of doing a hysterolaparoscopy for cyst drainage. But say for grading the endometriosis, if you are planning to do a hysterolaparoscopy to fulgurate the endometriotic spots, to improve the outcome because of peritoneal endometriosis, then drain the cyst or do a cystectomy. Yeah, this is again stage 1 and 2 with age less than 35 years, then ovulation induction around 6 cycles, even gonadotropin IUI can be planned. But as rightly said, that age is a very important criteria. And after the age of more than 35 years, maybe maximum of 2 IUIs can be done before IVF. Sheetal, can you take
Yes, I'll start with the case number 3. The woman is around 37 years. She's nulli gravida. Her bilateral tubes are patent. The semen analysis is normal. The TSH and the prolactin is normal, but her AMH is 0.5. Next slide, please. So what would you do in this patient? Shrutika, can you just put this? Yeah. Anybody, Yuvraj, you want to take the case?
Uh, I think I think all of us would anyways want to straight away go ahead and do an IVF. But practically speaking, if the patient to try maybe a month or two. My cutoff would be trying 3 months. Again, duration of infertility, marriage, all that is important for us. We've all, I think, learned with as time goes that sometimes just a low AMH or that isn't the only criteria that decides a natural pregnancy of a patient. So if the patient is newly married these days, 35, 36 has become a very common age for marriage. Patient has not tried at all and insists. But it's always a counseling on both the sides that look, your AMH is dropping. I would definitely prefer that you go ahead and do an IVF as soon as possible. But if a patient, say for example, says that we've not tried at all, sir, and maybe a month or two we would want to try, I would say I would give them a fair chance of 3 months. If sorry, but even if I go back to the previous case, I would give them a good try. 32 years old, 2 centimeter endometrioma with nothing else, just endometriotic spots, I would give them a full trial of probably not one or two, probably if they want 3 IUIs, if they don't conceive, because I'm not worried that her AMH is going to go down in 6 months of time of trial. So similarly here, these days, practically speaking, patients, unfortunately, with awareness, look for natural trials, and they kind of sometimes insist. And IVF has got a very negative connotation to it in a lot of areas. So I would not straight away just scare them that IVF is an only option. So yeah, but I would love to do an IVF. If a patient insists, I would give them a 3 months
I think
trial
like
of
how you
natural.
mentioned, because she's very young, I think 32 is a very young age, as in if because you're discussing about the previous case, I think 1 cycle or 2 cycles of
Yeah.
gonadotropin is definitely that we can try, provided rest of the parameters are good. Now about this case, I think won't you want to see other aspects like the antral follicular count and stuff like that, as in anybody has a
Yeah, so I'm just assuming that everything else is normal because we are not talking about male factors in the slide. So I'm just taking it for granted that rest all of the parameters are normal, and this is the only thing that's abnormal, which is just the AMH. And yes, I think validly, probably very important thing that you pointed out is sometimes just an AMH is not something
yes.
that decides the actual curve. Sometimes an AMH comes out to be less, but at the same time, when you do an ultrasound, two things, of course, ovarian volume and AFC sometimes comes out to be great. And also whether they have had long-term suppression. Some patients come with 3 to 4 months OC pills and everything, and sometimes AMH unfortunately comes out to be falsely low. I would also do a repeat AMH if AFC doesn't
Yes,
correlate with
and
it.
I think the timing of AMH, if anybody wants to elaborate, so we used to think that AMH is not time specific, but there are a lot of studies
We
which
know
have
that
come.
the first, now we know that the ideal time is in the first few days of the cycle.
Yes.
Dr. Anaga Pai and Dr. Kanchan have been very silent on this panel. Are they around? Can you tell me whether any other test like FSH or anything should be done?
Anybody else? Yes. Can anybody add on to this? What all will you do other than the antral follicular count and any other blood test that you would do? Dr. Abhinaya or Dr. Shweta or Dr. Sandhya, anybody?
Dr. Anaga Pai is also here, I think. She's.
Am I audible?
Yeah.
Yes, please go ahead.
Yeah, sorry to join late. So I'm just entering the discussion. So
Yes, so this is a case, Dr. Anaga, who is around 37 with an AMH of 0.5. So what would be the next thing that you would do in this patient? Dr. Yuvraj has spoken a little bit about this patient. So what would you do?
yes, so certainly she's 37 with very low AMH, and I don't know how long they are married and how long the infertility has been there, but certainly she needs to step up, and as soon as possible we need to move towards IVF, because we know that every 6 months her fertility is going to drop significantly, her AMH is going to drop significantly. So she's the right candidate for moving on to IVF right away.
So
Yes.
I have a little bit different take on this. When the AMH is 0.5, what happens is obviously we have, as Dr. Yuvraj has said, that we'll check the AFC, and if it looks good, we can definitely wait. But the problem is our patients obviously they have the habit of googling so much, and then with the 0.5 AMH, they are scared out of their completely by their friends and family, and that their AMH is dropping and they might not conceive. So, and even if you give them time, they are out of that stress and that mechanical trying, it doesn't help. So what I do in such cases, sometimes I give them the option that you go for an IVF, you freeze the embryos, and then you take 4 or 5 months, and might as well that will give the pregnancy also, and also that would take care of if they want one more issue, because we are not just looking at one, we want to look at the complete reproductive potential of the women if she wants to have more than one kid.
So
that also
would any of you do any other blood test like the serum FSH or estradiol? So this was a very good fast track trial which was put in. So anybody does serum FSH on day 2, day 3 of the cycle?
Yes, I would
We
like to do the FSH so that we get an
yeah,
idea
I
of.
mean, we know that. Yeah, sorry, go ahead, Dr. Sandhya.
Yeah, so serum FSH on day 2, definitely if it is more than 10
Yes.
and more than 14, definitely, then in that case we are a little bit worried, so that we can at least tell her that her reserve is dropping faster. So yeah, I would do the day 2 FSH.
Yeah, Dr.
I
Yuvraj
think
is saying something.
I think, of course, not just theoretically, we all know that the progress of hormonal, decline in the reports, where you see a drop of AMH, and then of course FSH gives you an idea that how long do we have in terms of whether they're getting into an ovarian failure. But practically, I would never. I don't really do an FSH just to know that how much time we have. I think looking at an AFC and with our judgments, we totally get an idea of how much to wait and not. Uh, just a little difference of opinion, respectfully, with Dr. Sunday. I think today the problem is it's the opposite. When you immediately tell a patient of IVF, they read more of that, or you can conceive naturally even with this AMH and less AMH and all that. So, and secondly, egg freezing or ovarian embryo freezing is definitely egg freezing, particularly for unmarried women and all. But if in this case the patient is
In
anyways going
marriage.
to go to IVF, I would definitely rather ask them
So
to.
one answer by everyone. Who will do IVF directly or who will just do an IUI cycle, like a couple of IUI cycles? Maybe just one line if you can just add on.
Sheetal, if you
Dr.
can
Shweta,
just put the age of the duration of infertility, then we'll just a random number.
Maybe 2 years, maybe 2 years or 3
Yeah.
years, maybe.
Then IVF for sure.
Then IVF, certainly.
Dr.
That's
Shweta?
correct. So after 1 year of marriage, if she hasn't still conceived with the AMH of 0.5, she has to be recruited for IVF.
IVF. Dr. Sandhya, what's your take?
Same. If the married years is more, we can go for straight IVF. If
You
it
know
is like
what?
6 months, 1 year, then we can give maybe 1 or 2 months of trial.
Okay.
I like Dr. Sandhya's strategy a lot. When she said that you freeze the embryos, if the patient is saying if we still want to try, let them try for another 6 months.
IVF कर दो बस हमारा
No,
IVF
it's
कर
not
दो.
for that. Basically,
That actually
it
is a
gives
very
them the hope that okay, our embryos are frozen, we are not running out of our eggs. So that is the idea, and that has happened many a times.
yeah,
No,
it does.
but this is a red flag for sure. As in
Sure,
age
sure.
37, 38, AMH 0.5, anything AMH less than 1, I think it's a red flag, and we have to tell the patient. Counseling, I think, plays a very important role in all this.
I want to practice in an area where a patient is ready to freeze an embryo and then try naturally.
We have those set of patients,
No,
and
we
that's
have
why
even
it's
I
easier
have.
for us.
It was just in gist, but I would love that. I mean,
But
the
I have done that
unfortunate problem is, मतलब ये तो हम दोनों कर रहे हैं, natural भी कर रहे हैं और IVF भी कर रहे हैं,
And why not? As I said, it is for the complete reproductive potential. We're not
Yeah.
just thinking of one.
Yeah.
That is
Yeah,
the
So,
right,
okay,
right.
so if at all we decide to go for an IUI cycle and you are doing the stimulation of the patient and the patient has
IVF,
maybe around 4 to 5 follicles, not just 3 follicles, 4 to 5 follicles, what would you do? Would you still go ahead with an IUI cycle, 3 to 4 follicles, or you would want to convert the cycle to an IVF cycle?
No, I would go ahead and do an IUI. If
IUI
anyways an IUI, look, you are going to get those follicles, whether you're going to do an IVF or an IUI. In fact, this cycle, in case if it doesn't succeed, I'm going to counsel the patient that look, with whatever stimulation you're getting 2 or 3 eggs only. Maybe after one IUI, it will be easier for me to convince them that even after stimulation, you're not responding great, and probably you will not just need an IVF, you'll need probably pooling of embryos if required.
Yes, I
And
think
what
pooling
about
of
the
embryos
reverse?
is something which is very important.
What about the reverse scenario? Now, if you
Yes.
have done IVF, but you are getting only 2-3 follicles, would you now do IUI?
No.
No,
Never.
at 37, you would actually expect a poor response. So you must, by this time, you must have counseled the patient about this kind of a response. So I don't think doing
In
IUI
fact,
is right in this
In fact,
case.
I would go a step further. I'm going to do a dual stimulation, get more embryos, hopefully blastocyst, and counsel the patient for a PGT, probably to get a higher result, lesser chances of miscarriage, and of course, the rest we know about.
Basically, the patient that we were discussing was Poseidon type 4. So, but again, how many of y'all are actually doing dual stimulation? I think just for the
Is
understanding
it
of
dual
the
stimulation or two stimulated
two
cycles?
stimulations, yes. All
Yeah,
of you, can you just say what would you all prefer? I would prefer doing 2 different stimulations. What's your take?
So with 0.5 AMH, definitely on the starting of the cycle itself, we have to counsel the patient that she
Yes.
might need a pooling cycle. So
Yes.
with the response which you have shown, it is expected with 0.5 AMH. And I would prefer to do 2 separate stimulations rather than a dual stimulation.
So my question, I mean, my decision would depend on the number of embryos. When I do the first cycle, and if I get 2 good blastocysts, I would love to do a PGT in this patient,
Yes.
provided if the patient agrees. If I get 2 good blastocysts, I might pretty much cancel my plan of a second stimulation and just go ahead and do a transfer. But if I get only 1 blast, or say something which is not of a good quality blast, then I would definitely go ahead and do another uh, stimulation. Want to put multiple blastocysts, provided 2 at least, for this patient of a non-PGT embryo, and if it's a PGT, probably even a single transfer.
As Sheetal rightly mentioned, this is Poseidon 4, and we get these kind of scenarios where there are only 2 follicles, there is only 1 follicle, there are only 3 follicles when you are stimulating for IVF. So what is your personal take if each of the panelists can say if there's only 1 follicle growing, would you still do the egg retrieval? If there are 2 follicles, would you still do the egg retrieval? What is your cutoff?
I would go
Yeah,
ahead with I would go ahead even if there's 1 follicle, because
with IVF.
We might not get that. Yeah, with IVF also, yes, because we might not get that one maybe later also. So, and anyways, we have counseled them for 2 cycles. So we are going ahead with 1 follicle as well in my center also.
So basically, I think there are a lot of studies where I think, especially for poor responders, so there is Dr. Marcus, where in fact they've done a lot of studies. When you have just 1 or 2 follicles, there they give stimulation with maybe oral ovulagens, and if there is only 1 follicle, they just keep doing IUIs back to back. So those patients, whether you're doing an IVF or doing an IUI, the success rate is almost similar. So again, that is something that we need to
Sorry,
decide
but
what is best.
I would not agree to that, and we have already discussed the fertility of Indian patients. So I
Yeah,
think
so I agree, because I was just giving a scenario that was discussed in the
Okay,
Western.
Sheetal, another problem with continuing with IUI is that, IVF at least gives you an opportunity to know whether the embryo is coming up. Just seeing a follicle and doing an IUI is giving
Yeah, a
just
lot of times they are empty follicles. You don't get
there
an
are
egg. You
empty
don't even get
follicles
a.
in consecutive cycles. At least we get to know where we stand, and then the probably this girl probably has a high FSH, and even not just the count, but the even the quality has really gone for a toss, and probably it helps us to counsel them better. So rather than giving up, a good counseling will help you.
Yes,
To
counseling
continue
I think
the
plays a
cycle.
key role in any IVF
Yes,
or
yes.
IUI or any infertility patient.
But having said that, I think all our panelists are kind of tending towards IVF, even if there is a single follicle. But what Sheetal rightly mentioned is it is the Indian scenario. AMH is 0.5, it is not 0.1. Now, after the ART law, we are all doing all these stimulations for lower AMH. 1 follicle growing at 0.5 is rather low, and Indian patients are paying out of pocket. So sometimes converting to IUI, because the literature is in favor, like Sheetal said, most of the studies are saying that IUI or IVF will not make a difference with regards to success rate of the, and time taken to conceive when there is monofollicular growth. At the same time, I agree, it's a hard call to make. Patients want
Yes.
IVF, we do IVF.
So
Yeah.
basically, the cumulative pregnancy rate is much higher if you do back-to-back IUI cycles where you're just giving maybe clomiphene citrate and you're just giving tamoxifen to kind of suppress the LH surge. So in that case, I think that was the scenario that I was discussing.
It's just that there is a lot of see, previous two cases we've discussed in 32 years and 35 years we'll not do more than 2 IUIs, and now at 37 years with unique monofollicular count. I mean, yeah, I totally respect and get what both of you are saying, but I would want to ask both of you, would you do an IUI
Yes, of course,
and
because the
convert this patient?
patient is paying out of pocket at 0.5 AMH. I think one follicle growing is very low. I would want to change strategy. See, sometimes what happens is patient has that 1.5 lakhs only to do that IVF cycle. You sometimes have to convert to IUI to save the patient's money and change strategy and stimulate again. So those
So when
scenarios
you have
do occur.
If you ask me, if you have given a gonadotropin stimulation, I'm just being very honest, what I would do in my clinical practice, if I'm giving a gonadotropin stimulation, I would go ahead with an egg retrieval, because any which ways the patient has paid for injections and stuff like that. And even if you get one good embryo, maybe that way. But if the patient has just taken mild stimulation, I think I might think about doing an IUI cycle as well.
I think that's very
So,
fair. Because at the end
I
of the AFCs 2 and 3, what miracle are we expecting in the next cycle? Maybe two follicles?
So actually, our treatment strategy will change at day 4 or day 5 when we are doing the ultrasound. Then, if we are seeing a monofollicular growth at that very time, it is that very time the patient needs to be told, this kind of a stimulation hasn't worked for you. In this cycle, I think it's better you go ahead for with IUI or even a natural try, because your age is 37, and probably month or 2 months later we change our treatment and then go
Maybe the
ahead with IUI.
protocol can be changed. Maybe you can add a june,
Exactly.
like you can
So
give them
that decision can be
antioxidants.
taken at day 4 or day 5 when we are actually doing this
Early
plan.
conversion can sometimes save cost. Again, definitely, it is a red flag. We are not debating the fact that a person who is Poseidon 4 does not require IVF. We definitely are saying it is a red flag for doing IUIs again and again. But sometimes you have to change strategy midway also.
Okay, next case.
Yeah, fourth case. Patient's age is 30 years, married since 2 years only. Nulli gravida, primary infertility, diagnostic laparoscopy is normal, semen analysis is normal, all hormonal profiles are normal. Previously, 3 ovulation studies have been done with 3 previous failed IUI cycles. What next for this patient?
IVF.
After 3 cycles or 6 cycles, previously some of the people were advocating 6 cycles, and we know that in our
Shrutika, no, I don't think any IVF consultant is going to go more than 3 to 4 cycles. But yes, we've all had experiences with gynacs. So
yeah, so people go doctor shopping, they go from center to center, end up
Yeah.
doing 10, 15 IUIs also.
In the first case, what Sheetal mentioned is very important here. If the patient again is insisting that we are very young, and sometimes they just come to you to not go for IVF. That's their agenda only, which is very clear
and
in
also, Yuvraj, I think when the stimulation is done, sometimes people give alternate day injections and gonadotropins and all kinds of things. So I think it's very important
what you
to see
said,
the
that
protocol.
what the previous 3 IUIs, how they have been done, whether there is actually a pre-wash, post-wash report. Sometimes there is just nothing. It's just IUIs happening and you have nothing in your hand. Giving the benefit of doubt, I might say that, okay, let me try once. Probably not something I'm recommending, but only and only because you're insisting, and probably the places where, so for example, someone from Sheetal and Shrutika comes with me with 3 IUI failures, I'm not going to say that I'm going to do some magic. I will be very sure that I'm going to go for an IVF. But unfortunately, if someone has done it at places where the gynacs we know have for some reason not used the right protocols, there have been the trigger has not been right, or the endometrium has not been correct, and all that thing, then probably more trial because of the age. But otherwise, good 3 IUIs, 30 years with so much of stimulation already going on, definitely counsel them for IVF.
Dr. Kanchan has been silent on this panel. Would you change strategy? Like Yuvraj mentioned, it depends on the protocols. If those 3 previous cycles were, say, CC cycles, clomiphene citrate or letrozole cycles, would you like to still try a gonadotropin IUI after these 3 failed IUIs? Is Dr. Kanchan around?
Is there any other panelist who's around? Because I can only see 4 panelists. So if there's
Yeah,
anyone, they can take the
are we
question,
missing
please.
anybody? Dr. Samida?
I don't think Dr. Samida has joined. So anybody else, as in
So
what?
if previously only clomiphene was given, as in this case, the age is only 30 years, definitely we can try a cycle with gonadotrophins. So because the success rate of IUI is more when gonadotrophins are used.
I would agree with Abhinay that it is unless the IUI cycles have been done properly with gonadotropins with multiple follicles, I think it is worthwhile giving another try. If everything else looks normal, there is no harm in trying another IUI cycle, considering her age.
And if we are anyways planning to go ahead and try naturally or IUI, I think then is time to also evaluate a little bit more. I would change my strategies to seeing the DFI of the husband, not just doing a plain IUI, maybe considering a microfluidic IUI for this patient or something like that. Little things probably also would
Very important points, Yuvraj. Yes.
Yes. Again, see, this case is classified as unexplained infertility. And although IUI is the least costly treatment, generally the literature says that after 3 IUI cycles, that like Yuvraj said, we should at least suggest IVF to the patient. If the patient doesn't agree is a different thing, but at least on paper, document that you have recommended IVF in this situation.
Shrutika, I think I did one talk somewhere and I was talking about unexplained infertility, and someone from the UK fought with me that there is nothing like unexplained infertility, which is, I think, very, very true, because maybe we've missed on some finding and there's nothing called as unexplained infertility. So I think that after 3 cycles or 4 cycles of IUI, I think it makes more sense. If everything's done correctly, maybe to shift over to IVF.
Yeah, unexplained infertility means that you have done all the conventional tests.
Yes.
Now that guy might be fighting, but if he is from NHS, he should
Yes.
know the limitation of where they can't even prescribe investigation like we do.
Yes.
So, fine combing through the case to actually pinpoint whether the microbiome is problematic or not.
In fact, the NICE guidelines even in fact said that if there is unexplained infertility, don't do anything and then directly jump for IVF. So
Yeah,
I think
so you can't say that there is no entity called unexplained infertility.
yes. Next situation, next
That would-
case.
yeah.
So the age is around 26. She has regular periods. Her HSG is normal. Her hormonal profile is normal. Her AMH is 3. The semen analysis is 10 million per ml, and there is a 40% progressive motility, and she has 2 failed IUI cycles. So anybody, would you still continue with an IUI cycle, or at 10 million count, would you do IUI at the first place? I just want to know everyone's take on this.
So to consider IUI, whether to plan IUI, she has already had 2 failed IUI cycles. So I would first re-evaluate her with especially the semen count being only 10 million. I would look for her previous reports. What was the pre-wash, post-wash? I would also check for a TMMC. That is the total motile sperm count. So that is an important factor which helps us in deciding whether we'll have success rate with IUI. So if the TMMC is more than 5 million, then I would definitely consider an IUI. We can, as it was pointed out earlier, we can also check for the DFI of the husband, the DNA fragmentation, and if it's high, we can go for the other sperm wash methods like the microfluidics, which has a better success rate.
Dr. Abhinaya, that's a very nice point you made about TMSC. For the benefit of our audience, can you tell us how to calculate TMSC? What is TMSC?
It is VCM, which is volume into concentration into motility, the percentage of all 3. So that is TMSC.
Yeah, so this is something that we should, when we are reading old IUI reports, this is something that it is not mentioned directly. It is something that you can, manually calculate in your mind. And this is something to look for to know whether this IUI can be continued any further. Yeah, can you?
And I feel it's better to, when we are doing IUI, it's better to calculate the TMMC and mention it in the reports.
Every
time. So when the count is on the lower side and the TMMC is slightly lower than 5 million, would you put the patient on antioxidants? What would you do, or you will directly jump to the third IUI?
I'll check for the hormonal evaluation. If there is any scope for improvement, I would definitely try.
So if that what hormonal evaluation can be done for this case where it is oligospermia?
I would check the FSH levels. If the FSH levels is high, more than 10, then there is no scope for improvement, and he might deteriorate further. In such cases, I would directly counsel them to proceed with IVF rather than trying another cycle of IUI. Whereas if there is testosterone is low or the T bar E ratio is altered, in such cases, we can try the medical management.
Okay.
I would also
Dr.
do a
Yuvraj?
hormonal profile in the sense the TSH and sugars of the male patient, because that is most of the times we tend to miss. We focus more on the female, but with the other with the FSH testosterone E2, I would also do TSH and sugars in the male partner.
I know
And
Dr. Yuvraj does a
correct.
lot of male infertility practice. So, Dr. Yuvraj, in this case, Dr. Abhinay has mentioned T by E ratio. She has said FSH levels. What would you be your plan of action? Would you do any medical management in terms of hormones or letrozole or anything?
Yeah, I think we would simultaneously start the male management irrespective, even if you're going for a third
It's
IUI,
very important. Yes.
because at the end of the day, that would go concurrently, simultaneously. I think Doctor mentioned it correctly. Just a small difference of opinion. FSH more than 10 doesn't mean we cannot give medical therapy, provided, which of course she mentioned later on, provided the testosterone is low. So the FSH cutoff can be more, provided your testosterone is not adequate. So the cutoff for testosterone to give medical therapy is somewhere around 400 to 600. So if in case the testosterone is 600 and your FSH is 10, 12, 20, whatever, then you know that your body is functioning at optimal stages. No cyphine or anything would help. But say for example, your FSH is even 15, but your testosterone is even 200. Then there's still scope of stimulating this male patient. In fact, you can go as high as giving them gonadotropins to increase the testosterone levels to 600, and you might see a good response in terms of the count and motility. Plus, as
So,
Sheetal said, antioxidant is definitely, I mean, that's a no-brainer that goes along with all of it. Along with that, very, very important, do a physical examination to rule out grade 3, grade 4 varicocele. If there is a
Yuvraj,
grade
Yuvraj, I am not, I don't want to break your whatever, but would you involve an andrologist in the process? Because sometimes, like how you mentioned, examination is very
Yes, I
important.
would. I have the liberty of having. Yeah, I mean, I have a very great andrologist on the team. I would definitely involve them. But the management would definitely, because I mean, the only thing I am still not very confident is to clinically palpate this male patient for varicoceles, and such patients, young patients, insisting on still giving natural trials at 10 million if they have grade 4, grade 3 varicoceles of clinically palpable varicoceles, then these patients would definitely help with microsurgical varicocelectomy and medical therapy, provided the hormones are correct.
yeah. Dr. Sandhya, what about E2 levels and obese men? Would you like to have a look at the E2 levels of these obese men and do something about obesity, especially with vis-a-vis oligospermia?
So, as we advise lifestyle modifications for females, same goes with men. More like they are, if they are obese, then that increases the ROS, and obviously there is a problem with the morphology of the sperm. So, and also I would like to do a DNA fragmentation in such patients, because we have seen that even with normal sperm count and motility, the fragmentation is extremely high because of their lifestyle habits. So I think yeah, so weight loss, I mean lifestyle management plays an important role in male infertility as well.
Yeah, so when there are high E2 levels, you
Rika
can.
has pointed it out extremely correctly. I remember, these are the words etched in my brain. Dr. Rupin Shah used to say that basic infertility hormonal profile, if it's an obese patient with FSH and testosterone, you need to add an estradiol. I mean, we would love to do it for everyone, but in case you want to skip an estradiol, then a normal BMI patient, probably if you skip, is still fine. But if there is an obese man, there is a very, very high chance that your estradiol levels are going to be high. And that would change the strategy in a way that then these patients would not respond, would rather respond well to anastrozole or a
Absolutely.
letrozole rather than a cyphene as an replacement for medical therapy.
Also, one more question is that not related to the case, that if the semen analysis or the count is less than 4 million or around 3 million, do you all add a karyotype? So how many of you all actually add a karyotype when the count is quite low?
Yes, I do the karyotyping and the Y chromosome microdeletion, both of them for
Okay.
such low counts. So, because, that helps in counseling and categorization, I mean, the prognostication of the patients as well.
Yes.
So yes or no answers from all the panelists. Do you all do sperm DNA fragmentation as part of evaluation for every infertile couple, even if IUI cycles are planned? Or when in your course of your management would you do SDF?
You can start, Dr. Abhinaya.
Yeah, I don't routinely do sperm DNA fragmentation in all cases. If she has previous failed IVF, definitely I will do before I take her for next cycle. In previous failed IUI cycles also, before I take her for the next cycle, I do. But in cases of unexplained infertility where everything is normal, where the male patient age is higher, or if the patient gives history of any smoking, all those cases I would go ahead and do in sperm DNA fragmentation.
For IUI failure, how many of you all are doing SDF?
When
Dr.
the
Yuvraj, Dr. Sandhya, Dr. Yuvraj?
I'm quite liberal in my DFI assessment. So I would do it whenever possible for a lot of patients, irrespective of IUI or an
And
IVF.
how do you work the cutoff, Yuvraj? Like, how do you decide?
Sorry, cutoff
So,
for
cutoff
DFI,
as in, yes, for DFI.
IUI or IVF?
Yes.
I mean, we all know that the cutoffs for poor and excellent DFIs are somewhere around, you can range it from 30%, but I don't really decide on just because the DFI is high. For example, this same patient, if the DFI would have been high, she's, I guess, 25 years old or something was mentioned.
26. She's
Yeah,
26.
I wouldn't straight away jump to an IVF for a patient if just the DFI is high, but
Even if the
definitely.
DFI is more than 25?
Yeah, even if the DFI is more than 25, I would like to give them a chance.
And
I would like to try to correct it, wait for 2 months. Again, rule out these known causes of high DFI, lifestyle modification, varicocele, local examination, XYZ. And then, of course, if it's persistently high, also sometimes when the DFI is too high for these patients, controversial, but I would still go for a urine culture. Sometimes it's infections also, sorry, not urine culture, semen culture.
Semen culture.
It's the infections also that lead to very high DFI. Try to find out a source of DFI. But at the same time, if this patient was a 37-year-old with an high DFI of 25, I would definitely directly say that just go ahead and do an IVF.
Yeah. Dr. Kanchan just joined, I think, briefly. Is she around? Is there a
Yes,
change?
ma'am. Yes, yes, I'm there.
Dr. Kanchan, you can.
So high DFI.
Yes, yes.
High DFI patient, whether for IUI or IVF, currently we're talking about IVF, would you change the semen preparation method for this patient?
General, yes. So generally, we can opt for sperm selection techniques like microfluidics or magnetic assisted cell sorting. We can think about this sperm selection techniques, which can give good results in the patients basically where sperm parameters are deranged, where we see teratozoospermia, where we see motility is hampered in these cases, and where there is a high DFI.
Dr.
In these
Kanchan,
cases,
just
we
to
can
add
select.
one thing, you said that you will do MAGS. MAGS is more of centrifugation. So when the DFI is high, MAGS is not the answer. So you can say Zymote or you can say some kind of other microfluidics. But definitely it's a big no for MAGS.
Yeah, max, I think you have to centrifuge twice.
Twice,
Ending
yes.
up
So
increasing the
that is
DFI of the
definitely
patient.
not part of the treatment.
But microfluidics, I think rightly, as you said, that is something that may work. And there are some people who are trying microfluidics even for IUI samples.
Yes.
So you can think. But what about swim up and density gradient? Any preferences there? Anybody with an interest in embryology?
So density gradient is not the correct technique because again, it uses a lot of centrifugation. So if nothing is available amongst these latest technologies, then it is swim up.
Swim up, yeah.
Just to add one thing, many other times in such cases, if we can ask for a second repeat sample and processing that would also help. Our embryologist generally does that many a
In
time.
fact, sometimes the second sample is much better.
Much better, yes.
Yes.
So frequent ejaculation, using the second ejaculate is some of the techniques that are suggested by andrologists. So asking your patient to ejaculate every alternate day or every 2 days reduces the DFI. So that is, I think, a very, very sound and practical thing. Sheetal, will you take this case?
Yes. Age is 26, regular periods, all hormones are normal, HSA is normal. HSG shows right-sided tube which is not visualized beyond the ampullary region. Diagnostic laparohysteroscopy confirms the tortuous right-sided tube with no free flow of methylene blue. Left side is normal, HSA is normal. She's just 26. So what would be the next step?
So unilateral tubal blockage. How do you all counsel the patients? Dr. Yuvraj? You
Yeah.
say IUI only when the follicle is rupturing on left or directly
Yes.
Any such ideas?
No,
Or
I
no
mean,
at all?
sorry, I could not get what you asked. Sorry. If we are
So,
just talking about this case,
yeah,
sorry. Yeah.
this case only, since the left tube is patent and the right tube is kind of blocked, it is
Yeah.
tortuous. Okay, we
Yeah.
don't know anything more. There is no spillage from there. Patient is young. She has everything otherwise normal. Would you do IUI cycles? And if you do IUI cycles, would you tell the patient कि only left पे ovulation हुआ, so then only we will do the IUI cycle? Or would you jump to IVF directly in this case? What about this case? Because this is a pretty common scenario.
I'm assuming we have tried cannulation and it's not worked, right?
Would you do cannulation for this patient directly?
I mean, if you are going and done a diagnostic laparohysteroscopy, I would probably have tried to open the tube, and if it opens, fair enough. If even if it doesn't, I mean, yeah, I will play the merry-go-round here for a month or two. एक ट्यूब से conceive करने की try and all that. Definitely, I mean, unfortunately, I will not have the guts to say that go straight forward for an IVF at 26 years old. But yeah, I mean, yeah, I would try for a few months with a single unilateral tube. No, not an issue. Provided and but the only thing is my trial period will become a little less. I mean, I'm not going to now wait for 6 months and 1 year and just keep on trying multiple IUIs and all that. That threshold will get a little less. But if you ask me, will I directly next month go ahead and straightforward do an IVF? No.
So see here there is an ampullary blockage.
Yes.
So probably there can be fimbrial, kind of inflammation or endometriosis or something like that. Does it make a difference whether
Yeah,
it's
but
a proximal kind of cornual block?
diagnostic the laparoscopy has been, so I will be sure know what is the cause.
So if it is maybe an inflammatory condition causing a ampullary blockage, does it make a difference?
I
So
mean,
I think
I would, if it is an inflammatory condition, the only thing I would practically do is I would give them an empirical chronic endometritis protocol just to rule out the infectious part of endometritis for this patient, and then probably give it a try.
And in our country, tuberculosis is also something that we
Very
should
common.
see when there is an ampullary
Yeah.
kind of tortuous
Yeah.
ampullary tube which we are seeing. And maybe in such cases, then sometimes IVF might be a little better than a cornual block. Tubal
Yeah, I would
recanalization.
So
I
how
would
many of
normally
you
call
believe in tubal recanalization?
Yeah,
How many of
because
you all?
unfortunately, unlike Yuvraj, who has everything at his disposal in the first go, in our country, many people have the impression of doing diagnostic hysterolaparoscopy. I agree it should not be done. You should be prepared for everything. But then would you pose this patient again for a tubal recan?
I mean, I would.
You would?
You would?
See, you just see. We
So
are talking about
actually,
just
I would
only
like to
block.
differ. If she has come to me with a report that she has a ampullary block on right side and she is young, 26 years, I would actually counsel her that let's try ovulation induction. Whenever you are ovulating from the other side, let's give it a try then, because her ovarian reserve is in our side. Probably I can tell her that for 6-8 months you try like that. If nothing happens, then okay, we will proceed with the. I mean, I
But
will not
does
even mind actually trying IUI for her, a
but
stimulated
does the
IUI
side
when
of
she's
the
ovulating
ovulation
on the
matter,
correct side.
Dr. Shweta? As in which side the patient ovulates, does it even matter in an IUI cycle if one tube is open?
I mean, if we are talking about that, the ova will travel from the other side. It's a debatable thing. But if I am actually taking her up for an IUI, if she is spending 15,000 rupees, I will definitely like to do it on the side, on the correct side. The IUI when she's ovulating on the correct side.
So tubal
I just feel also just very practically, I would want to see the recording of this diagnostic laparohysteroscopy, to be very honest, before deciding whether I'll try a cannulation or not. Now, if they have good pictures and if there is a video that shows that this is, we would all come to know how feasible it's going to be. If it's a bad tube, lot of inflammation, lot of adhesions, we know that everything has been done well, then of course never try a re-laparoscopy for this patient. But if it's just a random HSG showing a unilateral block, I would definitely think of doing a cannulation. And TB, as Shrutika said, my till now I always get confused with my TB tests and call Dr. Shrutika Thakkar to ask
But
what,
this
what
one, she doesn't have a ampullary block. They're saying it's a dilated and tortuous right
No,
side
no, there is an
correct.
ampullary block.
There's a
So will you
block.
actually
There's
like
a
to
block.
repost her for a tubal recannulation? Had it just been a corneal block? Yes, definitely. But
No,
what
they've
about for
written
a
it's a
dilated
block.
tortuous
I
tube?
think they've written it's a block.
It's a block.
I
It's a
think.
It's
block.
a block. It's a block.
Yeah.
But it's a dilated tortuous tube also.
With that,
With that, yes. So will we actually like, I don't know, I mean, I'm here to learn, but
I
will
would
we
not
actually
recanalize. So that's my
So I
take.
think
But then,
most of us don't understand this scenario because most of us, like Yuvraj said, we would have tried it at that go there and then.
Yeah.
Again, there's a difference between recannulation, where you are just passing a ureteric catheter through the tube to just see whether the tube is still patent, and the recanalization surgery. I think the data is very clear that only for tubal reanastomosis after any previous family planning operation, tubal ligation operation, there probably the success rate improves if we do a
yes,
tubal recanalization. Otherwise, the cost of IVF is also less than this kind of tubal recan surgeries. So IVF has a higher, per cycle pregnancy rate than trying for tubal surgery. I think that era is little bit
yes,
gone.
and if it is recanalization where you are just doing the sterilization, there the tubes are not damaged. So even if you
Correct.
consider doing it, it makes sense.
In our
Otherwise, when the
scenario,
tubes are damaged, I really don't think it makes too much of a sense because it might also lead to ectopic pregnancies. So I think you have to tell that part also to the patient, and the patient has to get pregnant naturally.
yeah. Coming to our last case, 25-year-old
No, but
female.
I would still like to know what is your take of the other panelists on IUI for the single unilateral open tube. Will you people try or no?
I
I
think all
would
of us
try.
try. All of us have to
Definitely
try.
try. And again, according to me, which side the ovulation happens really doesn't matter because at the end of the day, the egg is going to go in, like it can be picked up from either side. So it doesn't matter.
Okay.
In fact, I would like to review this case whether she really has an ampullary, whether tubal block alone, or she also has a dilated hydrosalpinx.
Correct.
That
So
itself might be the cause of the infertility. And many a times, just blocking the tube during laparoscopy would make her pregnant in the next cycle naturally also. So I have had situations where just blocking the tube, if the tube looks significantly damaged, dilated, and unhealthy, and subsequent cycles, she might have a natural conception.
Yeah, so reviewing the
Yes.
images of that previous laparoscopy, if you haven't done it, I think that is a good point.
also, Shrutika, I mean, I was just going to say that I agree with the doctor that not a laparoscopy, of course, but a good ultrasound because it's sometimes dilated, tortuous, inflamed tubes are pretty commonly seen on a laparoscopy. They without also I'm just talking without a blockage also. They don't really signify, but provided you do a repeat good ultrasound and you see that these tubes have a element of hydrosalpinx or
Yes.
something, then
Clinically
of course
seen,
we're never going to.
hydrosalpinx have significance. Yes.
Yeah, then of course there is no point. We're not going to touch it. In fact, then we are not even going to counsel too much for a natural trial or an IUI, and we would straight away think of doing something more for this patient. But yeah, so that one thing that we need to do is reevaluate the patient with a good ultrasound probably, and see whether you're seeing an element of hydrosalpinx or inflammation.
Right. Moving on to our last case, 25-year-old female married since 7 years, menstruates only on withdrawal, PCO patient with AMH of 8. Rest of the hormonal profile was normal, HSD normal, HSA normal. You stimulated with CC, first scan after 5 days of CC, 10 to 13 follicles have been recruited in that follicle, and all follicles stagnated in growth. Cycle was abandoned. Second cycle, you gave letrozole 2.5 milligram for 5 days. Again, 11 follicles recruited. What will you do now this time? Patient hyperstimulates every single time.
Anybody?
Anybody?
Yuvraj, you want to take it? Dr. Shweta, you want to take it? Dr. Anaga, Dr. Kanchan, anybody wants to take this case?
Okay, I think the panelists have been making great, must cases. Okay, we are discussing ovarian drilling here, probably. That's the whole idea of how to take it further. I think for this patient, even at 25, my plan is at an EMH of 8 and an unstimulated or a non-responsive so-called stimulation. I would definitely take them up for an L plus H laparohysteroscopy, and I'm opening up, and I do think drilling is one of the this is one of an indicated cases of ovarian drilling, and then probably try doing the rest.
No, but here the
But
patient hyperstimulates whatever
yes,
you do. It is not under response. It is over response every single time.
Still,
so
I would like to do a drilling. I don't mind doing a drilling for this
what is
patient also.
everyone's take? It's very interesting. What would you do, Dr. Shweta? What would you do?
Drilling
So
being a
in this
solution
case,
for this?
because she recruits her follicles, but the growth gets stagnated. I would like to see her LH levels on day 2, and as well as her testosterone levels, and then probably down regulate her with 2 or 3 cycles of COCs, and then probably re-stimulate her.
No, so
But
now I think it is very specific what Shrutika has said, that second cycle there are around 11 follicles which are recruited. So in this scenario, what would you do?
we
Can
want to
I
Abhinaya?
speak?
So then convert her probably. If there are 11 follicles which are recruited on day 5 and they are going well, actually ask her for a conversion to IVF.
Yeah, Archana,
Tell her that she's at risk of OHSS, and it is
Yeah,
better
doctor.
that she should get going with IVF, freeze the embryos, and then later on do a frozen embryo
Can I
transfer.
add 2 things here?
Madam.
Number one is how easy it is to convert a couple who is not willing for IVF at first place and then convert it midway, right? We at this level find it difficult to convert, the conversion. And second thing, has anybody tried antagonist? Because whenever there is a like over responder, or you see, because day before yesterday also only we had young women of 25 with both ovaries 8 follicles just by Letoval. She grew up, and then we were like, oh, she will get into OHSS. Now she says, well, I don't want IUI, I want a spontaneously try. I said, then you are definitely going to get a lot of embryos, because there will be multiple pregnancy apart from OHSS, risk of multiple pregnancy. So maybe worth considering giving antagonist in these patients.
Yes.
Yes,
So
even
I
if
think, ma'am, as you rightly said, that patients are not going to agree directly from IUI to IVF. So I think counseling is something which plays a key role when you know that the AMH is more, when the antral follicular count is high. I think in the beginning, if you counsel, it is a little easier for the patient to agree for a rescue IVF.
Maybe what I like, I know I understand that rescue IVF thing, but I think then your counseling should be that strong to tell them to go for IVF at the first hand only. When in medicine, it has to be like you have to have, okay, IVF, and you have to tell the patient that there is a risk in IUI, and rather than midway converting, I think that would be my take, that either do a counseling very strong that patient is so much convinced that I have to go for the IVF at the first place.
also we need to know that rescue IVF, lot of times by the time we make the decision, the follicles are above 14. The
Exactly.
LH surge has also happened. So the embryos may not be as good as some patient where you have thought of IVF from the beginning. So when you're doing
Can
that, I think you have to
can we
also
ask
tell the
many
patient
of
for the
many
negative
of
outcome.
us that done how many rescue IVFs and it has worked? I think most of the times we, and also at this age, we're not talking about a 34-year-old who's hyper responded. So I think we all very rarely. I would rather cancel, to be very honest. If I'm scared, I'm going to cancel the
Exactly.
cycle.
I did the
Uh,
same thing, Yuvraj.
yeah.
I cancelled her cycle. I said nothing doing, we are not doing, not going ahead. Just let it be. And rather, I advised her not to try, in even intercourse. Otherwise, you might,
Yes, that is
sometimes,
also very
Very,
important.
very
sometime you might
important. Yes.
ovulate even after me stopping the medication, and you might get the multiple pregnancy and the blame will come on me that I didn't advise you and I'm not doing embryo reduction for that.
So Yuvraj mentioned
And
something interesting
and
about
even you too.
laparoscopic ovarian drilling. But any other medicines that can
Yeah.
be, when Madam
I
said antagonist, what about metformin, myoinositol, and all those things? Will they prevent this kind of scenario?
yeah. So I think you are absolutely. So we would cancel this cycle. I would cancel the cycle for sure. Make sure she's on these, insulin sensitizers. We all know that it's not going to change drastically, to be honest. But we have enough proof that these insulin sensitizers reduce little bit, chances of OHSS. Again,
Especially
I don't
metformin
know how much
does,
you would
yes.
agree. I think plus I go because I think ovarian drilling also helps get better response in terms of not hyperstimulation but reducing the chances of OHSS in this patient, and probably try a very microdose step up protocol if at all we want to go for an IUI and try other things.
So one thing that can be seen when you are absolutely deciding about a laparoscopic ovarian drilling, I think Dr. Shweta briefly mentioned it. You can do a day to LH. If your
Yes.
LH is anywhere about 10, above 15, then laparoscopic ovarian drilling definitely helps in these kind of cases. I think we are at the end of our panel. Sheetal, would you like to conclude?
Yeah.
Yeah.
Also, our AMH is 8, so I think the cutoff for ovarian drilling is 6.8 or 7 something.
So I think before we conclude, I think we just want one take-home message from every panelist that what is your red flag and how would you decide directly an IVF cycle? Like all of y'all can just give one take-home message. We can start with Dr. Yuvraj.
I think my red flag is male factor, which is most commonly ignored.
Dr. Shweta?
I think for me, the AMH and the age of the patient. If she's more than 35, her AMH is less than 1, I will definitely counsel her for a step up to IVF.
Yes.
Dr. Abhinay?
For me, the first red flag is the age. Age is the first one. And definitely I would consider the AMH and the duration of infertility.
Yeah.
Dr. Anaga?
Hello, I think for me it's the age and the ovarian reserve because that's something that we see more commonly these days. So ovarian reserve matters the most. That's what I feel.
Archana ma'am, you want to say something? As in we've almost finished the panel. So what's your take home or what's your...
I would say it was a very, very interesting panel. And
Thank you,
really
ma'am.
practical tips from all of you, all who are practicing IVF, all, there's so many things. I think this the way the panel should be. And if you ask me when to convert from IUI, means when to shift rather than IUI to IVF, invariably, I think all of us, those who are practicing purely infertility or purely IVF, we usually do not get a primary patient, right? You
Yes.
understand what I mean? We get a patient who has already had several cycles of ovulation induction, self, or by somebody's and thing. So I think the initial history, and then as I said again and again, I'm saying the same thing, initial counseling only, that well, I mean, IUI, we know the success rate is 15%. Even in the best of the centers, it is 15%. So you have to counsel it against the IVF. IVF, you have to counsel it for the IVF. So rather than, like IUI, I may offer IUI. My offering of IUI is very less because the patient comes to us, have already been through several treatment. But if they are not really keen on IVF, I would say, okay, 1 or 2 cycles you can try IUI. But my cutoff is again the same like others, age, AMH. And if somebody is hyper responding, rather than poor responders, which we know that they are not going to perform very well in IUI, but if they are hyper responder on oral ovulogens or gonadotrophins, they are no for IUI in my practice.
Thank you so much, ma'am, for such important points.
Yeah, I think thank you to all the panelists. It has been a wonderful panel. Everybody has given very crisp take-home messages. So
Just
thank
from
you, the
panelists,
organizers.
Kritika and Sheetal, the questions were really interesting for a topic that was quite common and simple, but the gray topics that you guys gave us a chance to discuss a lot of things.
Just want to add one point.
Yeah.
That whenever there is a semesis from out lab is a pathology, and sometimes the technician does it. So every time we should actually do the basic findings like basic sonography, AFC count, and semen analysis.
Ourselves.
That is very very important, because many time it may be wrong findings. Maybe we can find severe oligo, or sometime low AMH. Patient may be labeled as PCOS for irregular
28
menses,
weeks.
but she may be having low AMH.
Charo.
Yeah, so that basic evaluation of this patient is very important whenever the patient is coming to us for infertility.
Yes.
So, hi, good evening, everyone. Sorry for joining late. Kalyani here.
Hi, Kalyani.
Hi, thank you so much, Sheetal and Shrutika, for joining. I just wanted to take a moment and thank you both of you for agreeing to be the moderator on the first place. And in a very short span, I remember I think I just discussed 8 or 10 days back with Sheetal that will you be able to do it? And I think she said yes in the first go. And Rudri called up and you guys just agreed, and it was fantastic. And thank you all the panelists as well. It was such an interesting session. We had too much of fun listening to all the arguments. Even my daughter was listening. She's like, "Mama, इन लोग ने वापस argument start कर दी." I'm like, "It is supposed to be a panel." So it's so when someone says that you're arguing or you're discussing, I think that's the best compliment you can get as a moderator for your panel. So thank you so much, and congratulations to both of you and all the panelists out there.
Thank you so much,
Uh,
Kalyani. Thanks,
yeah.
ma'am.
Thank you, Basir ma'am, for
Yeah.
giving us this opportunity to have this wonderful session. And I think for the closing remarks, I'll just hand it over to Dr. Brajbala Tiwari ma'am, Secretary for MPSR.
Hi, good evening, everyone. It was very, very interesting panel and very nice discussion. So many take-home points and practical points. And as chapter secretary, I request each and everyone, particularly to support Baser madam. As you
Oh,
know, madam is
definitely.
very, very sincere academician and inclusive nature, and I think she is right candidate for Foxy president. So I request all of you to support madam for upcoming election, Foxy election. And my sincere thanks to all the delegates, faculties, and all the panelists, moderator, Dr. Hiten sir, for staying since beginning, and our guest, Dr. Meenu, Dr. Vandana ma'am, and Shrutika, Shital, Yuvraj, Kanchan, Shri, and Shweta, everyone. Thank you so much. And last but not least, Rudri and Kalyani for making this program so nicely. Thank you so much.
Thank you,
Thank you.
Brajbala, for the kindness. And we should like to thank UNS team for really making it seamless for us. Rishikesh, thank you so much. And
Thank you, ma'am.
yeah, so thank you everyone. Shruti, you are a wonderful person, always very helpful and very prompt. So
Thanks.
thank you. So I think let's say
Ma'am, can I
bye.
just interrupt for a minute?
Yeah, sure.
Yeah, I also wanted to request everyone who joined in today, has the faculty, my moderators, the panelists, the people who presented, even Basir ma'am, you. It's just a small request, because we will be hosting this as online or as a recorded session as well. I would like to have a 30 seconds of a small video bite from all of you, just mentioning that why they should be looking into this, viewing this recording session, and for whom this session was, like for, the gynecologist, for the audience. So if you could all just put in 30 seconds of your time and just write, just speak 1 or 2 lines and put it up on the group, it will really help us to promote this webinar of ours in the future, so that everyone who has missed out today will be able to attend it.
That's a wonderful idea,
Great
Kalyani.
idea.
That's really brilliant idea. Because the whole purpose of doing webinar is to spread the message, and look how wonderful work this young team of IVF specialists are doing. So I think this is a very good way of catching people's attention and to listening to such an interesting discussions which they had in even in the panel, and Hitendra's lecture and all the practical tips. I think brilliant. I'm just doing it right away, Kalyani, for you.
Thank you. Thank you so much.
Thank you, everyone.
You can now, Rishikesh, official thanks from UNS.
So
Especially,
ma'am, I
yeah,
get Rishikesh sir, would you be able to give it?
yeah.
Okay.
Give me a second. So, first and foremost to everyone, I myself, Rishikesh Chaudhary, a Group Product Manager at Universal Science, one of the India's fastest growing nutraceutical companies, which is actually committed to advancing evidence-based healthcare. And we come from the family of Focus 300, Focus 25, UNS, G3, and Primoza, all are leaders in the respective markets. So it's been a privilege for us to host the Fertilogix webinar series 4, actually a collaborative initiative between NPSR and UNS. Special thanks to Dr. Archana Basir Madam, a program director for us, and definitely NPSR and other local chapters for their invaluable support. We are equally grateful to our chief guest, Dr. Meenu Agarwal Madam, guest of honor, Dr. Vandana Madam, for their gracious presence. A special appreciation for the organizing team, again mentioning Dr. Archana Madam, Dr. Kalyani, Dr. Rudri, and special thanks to Dr. Brajbala Tiwari Madam for curating such insightful sessions. And we immensely thankful for our speakers, moderators, panelists, and all participants for their valuable contributions. Thank you once again for your time and continued trust in UNS. We actually look forward to meeting you at our next academic initiative. So thank you everyone for the lovely evening. Thank you. Thank you.
Bye-bye. Bye. Good night, everyone.
Bye. Good
See you
night.
soon somewhere.
Bye-bye.
Bye.
Bye.
Thank you.
Bye. Good night.
Can I end now, sir?
Yes, sir. Yes, sir. Please, sir.